I'm going to give you a hint.
Sternal
rub.
Sternal rub.
Painful stimulant.
Okay. You have to be pretty far gone for a sternal rub not to change your respiratory pattern. So if the person doesn't even respond to this and you're giving a real sternal rub, all right, that's going to be pretty unusual. We've taken patients, either flying them or driving them, and just sternal rub them enough to keep their sats up, their breathing going. Just annoy them, literally just doing this. All right, that's really important in a case of patients who are taking, they're on long-term NARC use. So can you think of patients who are taking, they're on fentanyl patches, they're on Dilaudid, they're on—
cancer patients.
Which type?
Cancer patients.
Cancer patients, a classic, right? Cancer patients, big. And
sickle cell patients.
I don't know of any sickle cell patients that are on chronic pain control. Copy that. Has anyone seen that firsthand? That's a pain control issue.
Doesn't it cause like a bunch of pain?
It does cause pain. And that's a good question. And the way it causes pain is because low oxygen in the periphery causes sickling of the cells. And
right.
When cells get sickled, they cause ischemia and pain, right?
Yeah.
So
the only reason I ask is because there's this frequent fire, and I'm sure Jonathan Garcia, you're running this like African American girl. She's like a younger chick out here in Mobile, and she has sickle cell, and she's always complaining of pain. And they're always like,
is it the one that always converts into SVT?
Yeah, not with, she didn't convert with me, but she does have sickle cell, and she's always wanting to go to the hospital for pain management, and they always seem to give her like I think fentanyl.
Where does she complain of the pain, out of curiosity?
Abdominal pain.
Okay, that's interesting. So getting back on track, with the sickle cell, if you do get a sickle cell crisis, this is one of those people that regardless of their saturation, high flow O2 may well be helpful. Because the more you push that O2 into the periphery, the more it distracts them from sickling, which means deforming their cells. That's one of those little known kind of secrets that if you get a person with a history of sickle cell anemia, two things come out of that: priapism occasionally, and obviously pain. So high flow O2 is helpful because localized ischemia is posited to cause that deformity of the hemoglobin. Anyone know why sickle cells, the trait, might exist?
It was from Africa. This insect would bite people. I don't remember exactly what it was, though.
What's the most common, outstanding, what's the most common and one of the most lethal diseases on Earth still?
Malaria.
Malaria. So the sickle cell trait is hypothesized to help reduce infection or damage from the malaria. And there's like 4 of them, and falciparum is the one that kills you. So, all right, for a nice side note. So let's go on real quick to the other NARCs role is patients who are on hospice. They may be on high dose NARCs. Sometimes you get a call, so-and-so isn't responding well. You look at them, you see them, check the respiratory rate right away. Bradypnea is your concern, and you get that hospice patient who's bradypneic, they're slow breathing, they're hypoxemic. What do you want to do? See if you can keep them breathing like this. Do not, under any circumstances, or I should say only in the case of like they're going to die and there's nothing else you can do about it, give them the Narcan and blow them out of there because you can kill them and make things even worse. So if you need to, bag them. Put a capnose sensor on your BVM, bag them with that, it works great. You're just street overdose or whatever, then obviously fix that. So going over to the calls today, the seizure patients. On the last guy, on the Chaz guy, the 40-year-old guy sitting in the chair was talking about dogs humping each other and everything else. Okay. I discussed with the one group how you could kind of tell that it's not an epileptic seizure, how you can tell that it's probably not an intracranial bleed stroke seizure, and how you could probably rule out a seizure due to hypoglycemia. Any clues on that besides the people that were in that group that I was talking to?
He was able to kind of walk him through it.
Well, what do you mean?
Like after seeing the video a second time individually with our
Yeah.
groups, squad 4 curse broke the computer and Zoom.
Yeah.
We were able to see the video, and it was kind of interesting how he was kind of walking his friend through it, like, hey, like something's off, like I feel weird, and then it was just progressing, but it was never like caught him off guard. I would say it was more like he walked him through it, and then he snapped right out of it. There was very little post-ictal. When EMS got there, he was able to flag him down and call him to him.
Okay, so that's really a good point. He was not post-ictal to any degree. Yeah, he was a little gorked out and tweaked because of whatever's going on. In his case, it was a brain tumor, but no post-ictal phase to speak of. Okay, without knowing anything more, if that's an epileptic seizure, it's incredibly unusual. All right, so what about hypoglycemia as a cause of a seizure?
He wasn't altered.
Oh, that's actually a good point, adding to it. He wasn't altered, but now remember, he was typing like this kind of call afterwards. So pretend you didn't know that he was aware of everything. He could have been residually conscious going out. Then he's doing that. He's out, I wouldn't think he's aware at that point, just looking at him. Then when he came back, he started kind of, talking, call the ambulance, or rather he actually explained the engine sirens and everything else. But let me ask you this. If you go into a seizure because you have low blood glucose in the brain, what part of that seizure would make your blood glucose come up? If you keep seizing from hypoglycemia, how many people do you see that wake up and they're okay again afterwards?
Is that like a trick question?
Huh?
Is that like a trick question? Because wouldn't you just break off the high or the glucose?
They don't wake up. Okay.
Yeah, they need the glucose to correct the problem.
Glucose, yeah, to wake up.
So you're looking at the treatment as kind of a diagnosis. Now you're going to check your glucose anyways because you just check these things. Every time I say it can't happen, somewhere, somehow, someone will say, oh yeah, I did. But in general, when you go to hypoglycemic seizures, your next state is coma. And then you die. That's how an insulin overdose does it. That's what will happen. And so in this, right off the top of the head, you can kind of rule that out because he woke up on his own. And the other thing, and the one thing he did look like, it could be, especially in the beginning, was what? Anyone think of a 3-letter word that might have explained him without seeing the future?
TIA?
CVA. TIA is just a temporary version of it, right? A stroke. So the way he started off at the beginning made me think stroke. But as a fairly dramatic stroke. Now remember, you could read that he was hurting, but he wasn't communicating that. He was just kind of like, something's going on, something's going on, something's going on. He lateralized. But if he had a bleed, bleeds don't wake back up, not without treatments. Think about it. If he's kind of created a intracranial mass of the bleed, it only gets worse until it's treated, until they get a cure. So it's not like you can get a TIA with a hemorrhage. You get a TIA with an occlusion. Hemorrhages, they just get worse. And he came right out of it. So what do you think caused this guy's episode? And of course, he had no family history. We didn't say that, but that was a...
He said he was a stuntman, so possible concussions.
That's actually a really good thought to have. What if he had kind of, recent history of head trauma, right? That's an assessment question. And how would you ask that question?
What do you do for a living, sir?
Stunt man.
Have you hit your head recently in a stunt, possibly?
Okay, so have you banged your head really hard? Have you been knocked out, had a fall, something like that in the past few weeks? Okay. What other differential questions might you be asking this guy? Assuming he had no history of epilepsy, right? He has no history of epilepsy, has no known history of diabetes.
Have you had this happen
Any
before?
new medications?
Very good question. No, he's never had it before. Hey, how come everyone's hats off? Other question.
Any like new medications he's taking?
Really good. No new medications.
Has he hit his head? Any trauma?
Well, that's already been asked.
Drugs?
Drugs, none.
Maybe have you been under stress lately?
How would that pan out? Yeah, I'm always under stress. Who's not under stress? Stuntmen are under stress all the time. So I'm not knocking it. I'm saying that how does someone answer that? Most people would say they're under stress. You know, excessive stress might cause a problem if they're hyperventilating, if they go into hyperventilation syndrome, that can cause a similar thing. What about travel? He's on the East Coast, been bitten by bugs, been swimming in freaking fresh water and gets amoeba up the nose, and now he develops encephalopathy. That's little things you can ask, but in his case, because we're not there to diagnose the call, it's really kind of some exclusion, so you help yourself narrow it down. It was a brain tumor. Created a mass effect, and he had a tumor. So if he had a tumor, you check his vital signs, what would you think his BP might be?
Elevated?
Guy?
Possibly a Cushing's-like response, maybe some elevation. Again, nothing to hang your hat on, but more just looking at this guy and thinking, what is it likely not a case of? And at that point, you're really limited. Now you're just speculating like we're doing now, okay? Until he gets a CT of his melon and an MRI, we're really just guessing. But for academic purposes, it's pretty good. Going on to the male in the bedroom in the hotel. Any comments on that? Anything, someone that saw the 3 phases of the seizure?
I thought it was pretty cool how he was like postictal at first, and then how he like transitioned into a tonic seizure, and then he went on into a full-on tonic-clonic kind of thing.
So that actually is a good thought. If you came onto that person and they're postictal in a call, many seizures you get to them, they've already resolved. Okay, what might be a good question to know? What are you expecting that might happen?
Like what kind of questions would I ask him, or what do you mean?
Let me rephrase it. So you walk on scene, you see this guy's postictal, it's reported that he had a seizure. If you're experienced, you might see this guy's postictal, but you want to be sure, but you usually have an RP. So they say, yeah, I had a seizure. What are your concerns?
I mean, is this the first time that he's having a seizure?
Yep, he's had a history of seizures. He's got epilepsy.
I mean, did he take his medication, or what possibly could have triggered it? Maybe he hit his head, or
okay. So let's go back to, you find him postictal. He had a seizure. He's on his meds. There's nothing unusual that we know of, but you've got to do your assessment and treatment of this patient. You've got to figure out a plan and anticipate problems. What do you do for this guy? Your vital sign come back normal, fucking typical postictal dude, little hypercapnic. He's breathing faster to blow off his CO2. His pulse rate's going to be a little elevated. His BP is going to be wherever. His glucose is going to be normal. What are you worried about? What are you planning ahead on? As a medic, you have to be thinking ahead.
Well,
Another seizure.
I'm worried that he's going to have another one. So,
Fox. Your thought is, what if he has another seizure?
Yeah, so you want to get your Ativan ready. have an oxygenation plan, and then position the patient, it's where they don't have a compromised airway or cause themselves any head trauma.
Okay, so the problem you expect is that he might have another seizure. So if you keep your Versed wherever it's kept, which is usually locked up, if you hear a seizure call, it's a good idea to put the shit in your pocket and bring it up with you on the call. Don't leave it down in the unit. But assuming you didn't know it was a seizure and you get there, you think it's a seizure. Them having a seizure, again, is not the biggest problem in the world. But if you're moving the patient, you're carrying the patient, and then they start having a seizure, it could cause a headache. Okay, it could lead to an injury. And who could you ask, the RP or the family? Hey, does he normally have one seizure at a time and is one and done, or does he typically have more than one?
I mean, if you were able to contact family, then you would ask that.
Yes.
But I don't think no one was around for him.
This is a
so-
scenario. Remember, there's someone.
So I guess
with his girlfriend.
just the Keppra medications that were there. I think there were some medications around him that I've noticed. Maybe check his wallet. I don't know. I don't know if it would be. I think we had a conversation with Campbell. He mentioned like getting into his phone, but I don't think that's really legal.
So thinking back again, if there's no one there, you don't know.
Mm-hmm.
And I wouldn't waste a lot of time on it. It's just a good question to ask. Have you had seizures before? Which someone said yes. When you have seizures, do you normally have more than one? Or is it just once every 3 months type of thing? If I know the person is prone to having more seizures, I'm more likely to get a line established right then and there, just in a secure line. So if they have one, I can immediately knock it down. All right. But with the IM meds, you could knock it down IM, and that usually takes, again, if you go IM, within 60 seconds. But it's worth knowing to see where this call is going. Then, of course, all the other differential stuff you ask. Why is he having a seizure now? Is he off his meds? Something changed? What have you? What was that first part when he was looking with his eyes? Just doing this number here? What type of seizure was that?
That's a focal, correct?
Yeah, partial or focal? When you remember in the very beginning, he starts doing this number here.
Yeah,
It's a partial.
Okay, so focal or partial, depending on which book, which time frame, they'll call it. If there's no loss of consciousness, it's considered simple. And if it's complex, it means they're out. So the next thing, yeah.
Sorry to interrupt, but could that also be considered like an absent seizure? Because he kind of like began looking away and was out of it for a little bit before he snapped back into it.
What?
He starts shaking.
I just had an absent seizure.
Ah, okay.
Did you ask something? That's an absent seizure. There's no
okay.
movement of the eye. Ocular gyrations are a form of seizure. Okay, so the absent seizure is what I'd like to call the high school student in class seizure. When I go, Grillo, what do you think about this? Huh? That's an absent seizure. All right. So it's exactly. So perfect. That's what they look like. You can't really tell they're zoned out, but there's nothing external except the fact that they're almost like just looking. The difference is if someone said, hey, what were you thinking of? Or what's going on? You're like, oh, I was just thinking about this. Well, now we know you didn't have an absent seizure. But if you say, what was going on? And you're like, what? What were you doing? Nothing. That's it. But the weird thing about an absent seizure is the EEG looks almost like a clonic seizure. If you ever seen it, it almost looks like VTAC of the brain. So the focal or local Jacksonian would be the classic. You see the localized seizure. Sometimes you see twitching in the face. Whatever it is, that's something to pay attention to because it may start small and it progresses to a generalized seizure. And someone said maintain the airway. How do you maintain the airway in these guys?
Just kind of hold their head and make sure it's open.
So just leave them alone. You're not going to make sure anything's open. Okay, I hate to say it to you,
I was thinking of that mom where she was just kind of like, she was literally holding her daughter's head, you know?
Yeah, she was holding it. And she was kind of like when the kid was flapping with the seatbelt, she took her hand off. Big deal. That's just because you're stressed out. And the mom has seen this before. You can see her, she's a freaking pro at this. The second video she has of her daughter going shit on the freaking couch is nuts. I mean, this daughter must have seizures like left and right. And she's documenting them clearly. That's why she's filming these for a neurologist or whatever to watch them. But the funny thing is, in every one of these seizures, and countless more, how much oxygen was given to these patients? 21%. Okay. How much respiratory support was given to them? None. How much airway support, maintenance, OPAs, handling, intubation, whatever was done for them? And they all lived. It's a miracle. Well, the simple fact is, if seizures were such a big airway issue, there'd be a lot of dead seizing patients. But instead, they have seizures over and over again. So why am I saying this? Because when you see a seizure, especially if you're a student or you've got a crew, there's a tendency to feel the pressure to do something definitive. Does that kind of make a little sense? But the simple fact of the matter is, epileptic seizures patients typically get hurt more by rescuers and bystanders than they do on their own. They nip their tongue, big damn deal. And so basically, if they're puking or whatever, roll them on their side. And yeah, if their head's next to something, like he was on the bed and someone said, protect his head. I can't think of a safer place to be on a pillow in bed. So leave them as they are. And if they become, what did you notice about the skin signs for all those patients? The excited delirium guy, the bedroom seizure, the chick in the car. How was their skin signs?
I recall there was
It looked normal.
Color-wise, obviously we weren't touching them, so we don't know, right? Although a kind of hot tip is if you see a seizing patient and they're diaphoretic, it's a pretty good hint they may be hypoglycemic. The typical diabetic seizures are diaphoretic. So going back, if you're assessing this person, and what's the background noise there? If you're going to make noise, butt off. I'm trying to talk so you can understand, but this is meant for your benefit and it's tiring. So at least give me the respect there. If you have a person who's seizing, it's really hard to assess the effectiveness of their respirations because you heard sometimes they're chattering, they're short, they're snoring, they're whatever. Watch your skin signs. I pulled all the medics before that I spoke to before this class to see if the experience was the same. And the vast majority of seizures, they do not become hypoxemic to a severe degree. I've seen one that I can remember who was turning blue. Now that was a worrisome case. If they're turning cyanotic, they have true respiratory paralysis. And the definitive cure for that person is to what?
Get out of a seizure.
Stop the seizure. Stop the seizure. If you try to bag them, what is going to happen? You might get lucky. But if they're not breathing because their chest wall is frozen, their diaphragm's locked, what are you going to do with the BVM to overcome that?
Just fill the stomach.
Fill the stomach. So you're kind of like in this thing where the biggest thing you can do is knock down the seizure. And I suspect a great number of these seizures don't die because the seizures typically last a minute or two. And the tonic-clonic phase is typically like a minute. If they're going status seizures, they'll come out of it, they'll pant. They're basically catching their breath again, if you want to think of it that way. That's why in their postictal phase, they're typically rapidly breathing. They're hyperpnic, they're breathing faster to off gas and retain CO2. Then they go into another seizure and they're okay. So if you do have a patient where they're like cyanotic and seizing, we can't RSI them. You can give them Versed, but have someone throw a nasal cannula on or maybe an O2 mask with high flow O2. And that way you can create a high pressure of O2, which will diffuse passively into the respiratory system. Barber, remember you were talking about the delayed sequence intubation, I think it was.
Yes, sir.
Can you tell a group what that is, what they do for those patients to oxygenate them?
I don't really remember.
Okay, so what they do is and I don't know, Joanna, you may have seen this in Loma Linda. I've seen it at one hospital. They put them on a nasal cannula at 15 liters.
Yeah, they would always do that on Loma Linda when they're gonna intubate. The doctors always want them on a nasal cannula at 15.
And how long can they stay apneic with that and survive?
I mean, I didn't time it, but it was longer than 30 seconds.
It sure as hell is. It's around an hour plus. Okay, so they may become hypercapnic, but that's not going to kill them. What they can actually do is literally blow out all the nitrogen in the lungs. They are 100% O2, and they have maintained apneic patients for tens of minutes on just that high pressure O2. So if the person's seizing, they're going to become hypercapnic because they're generating a lot of metabolic waste. Okay, that's not what kills you. Respiratory acidosis is not lethal in the short term. The hypoxemia is. So this is the way you can manage them. I prefer nasal cannula over a mask simply because if for some reason they have to puke or say someone was bagging them before, you don't have a mask trapping shit and possibly creating a route for aspiration or choking. So simple thing. So going over, Jared, we give a benzodiazepine to terminate seizure activity. How does that work?
It's because it's with the GABA, I believe, right?
Good.
The GABA inside the, so it's the GABA 1 and, or not 1, A and C let in chloride, and then the GABA B lets out potassium, which it increases the what do you call it?
If you actually name it, I'm going to put real whiskey in this.
Well, damn. All right.
You're 2/3 of the way. This is beer so far. Ties, can you make it whiskey?
It increases the threshold of the why can't I remember it?
Does it start with D or hyper?
I was not going. I was not thinking there. So all right, you got me.
Kevin Campbell, you started out, you got everything right so far. Super impressed. By increasing the potassium or chloride anions into the cell and allowing potassium cations out of the cell, what does it do to the state, the polarization of the cell?
Hyper depolarizes?
Not hyper depolarizes, that would trigger a seizure.
Oh, this is hyper repolarizes.
Hyper polarizes. Okay. Makes sense? So I wasn't expecting the subunits of GABA. I'm like really happy you saw that. Okay. So it's making the cell more polarized, more negative to positive. All right. And that makes it harder for the cell to depolarize and go into basically mental fibrillation. It's separating the enemies. Okay, imagine you have the negative and the positive inside a cell, and you don't want them to fight. The closer they get, they're more freaking ready to just lock in and go nuts. So you polarize them apart and make them more stable. Keep the enemies away from each other. However mental cue you use for that. And Eric Dixon, if this person was, say, the opposite of a seizure, they had OD'd on a benzo, or carbamazepine, or we'll leave it at those two. What is the antidote for that? That's a seizure right there, right there. See, doing it right there.
First, to start with F.
It starts with an F. Very good, Isaac Grillo.
I can't pronounce it though.
Yes, you can. You just have to read it left to right. Isaac Grillo, come out of your seizure. What is it?
What was your question?
Oh,
Exactly. Okay.
the
computer cut out. It cut out. That was it.
Yeah, that's it. I freaking. So Rommel Miranda. By the
Come
way,
on,
all
you
those
guys-
serious expressions watching your Grillo are calling bullshit. So, what is
I
it,
call BS.
Rommel?
Is this the one from the video?
Richie.
So mad.
Mr. Ritchie?
Yeah,
Is this the one from the video?
it's the one from anything. It's the one every single video mentions.
Brandon, I
Oh
know you.
no.
I don't remember it, but I remember seeing it.
And Hector Suarez put it out there, except he spelled it wrong. Flumenzaril. But good side, because I know what you're trying to say, Joanna.
Sorry, my dog is barking, but it's flumazenil.
Flumazenil.
Like the Narcan.
Flumazenil is a Narcan for benzos. Flumazenil. Now,
I
this
did
is
not know. Sorry to cut you off, but I seriously didn't know that Narcan was an abbreviation for narcotic antagonist. I was just.
You're welcome. This is why I go out of my way to boldface and show the connection, so you see that whenever you come with a trade name, there's a play on the words, like Xanax, anti-anxiety medication. Okay, and there's several others that I can't think of right now, but they're a play on the basically what the medication is doing, if you want to think about that. So those are sometimes clues that you can remember things. So flumazenil is a case, and why don't we carry flumazenil? I've asked this because back in the 90s when I learned about this, we'd have narc benzo ODs, and sure, you could reverse a narcotic, but they're still gorked out, and the hospital just gives them flumazenil. And I asked a couple of nurses why we weren't carrying that. Anyone think about why that is?
Does it have some harmful side effects if you give too much, or?
Well, potentially. Anyone else can think about it? I'm going to give a hint. Think of like hospice patients in Narcan and how cautious you have to be.
You could possibly cause them to have a seizure. If,
You could push them into a status seizure. Say they OD'd and they're a patient that has benzos. And now if you give the flumazenil, the reason was given is that you could make them essentially untreatable if they go into a seizure. And it doesn't matter if you paralyze them, because if you paralyze them with succinylcholine or norcuron or vicuronium, you're just going to paralyze the muscles themselves. The seizure's happening here. And that's causing the damage. The brain is doing VTAC on the EEG. And you have to stop the seizure in the brain. So when you give Versed or Ativan or Valium, you're not stopping the seizure here. You're stopping the seizure there. Super important thing to keep in mind when you're talking about benzos and combating seizures. And that actually brings the second point. I have to get this out to Ian in the field. If you have an infant, after a break, I want to show you a couple of videos, but when the kid is seizing, a small toddler or whatever, they're not likely to have the whole clonic seizure that you're seeing. They typically have a much more reduced seizure where it's just their eyes. They'll almost look like a dystonia where they're doing this over here. They're looking like that. That's also a seizure that needs to be stopped. It's not dramatic, but it's the same VTAC going on in the brain. Kind of makes sense? So you treat that the same way, knock it down until the kid comes back to normal. And that's what they'll do. Yeah, it's all about respiratory depression, but you have to OD them to cause that. And you have to OD them by quite a bit. After doing that, Christopher Bowie, can you tell me again how benzodiazepines work to stop seizures?
Yeah, I don't know if I'm gonna be able to explain it right, but with the GABA, correct?
Okay, that's a start.
Hold on, let me go on my notes because I took out some notes.
I'll make it pretty easy for you. If you can remember that benzodiazepines essentially act on the GABA receptors and hyperpolarize the cell. So it's less likely to go into its little seizure fibrillation. It's okay. I don't care that you know the A and C subunits, okay, or where, but I also included the video. Do you remember that one guy drawing the subunits, the actual ion channel, which is what a GABA receptor is? That's medical school learning. What we're learning is like, okay, they actually have to learn what it looks like. And how does he learn it? By having to, like, you did video presentations to kind of teach a subject, really to teach yourself. What is this medical guy doing? He's teaching himself, but how he shows his mastery of it is he not only just goes down to, oh, there's a GABA receptor and we know that Valium does something with it. It's actually showing which parts of the GABA receptors are affected, what the subunit looks like, how it looks like from the top, where everything's coming together. That's medical school level knowledge of pharmacology. That's when you know your shit. And that's what impresses me. I would wager 90% of these videos are made by freaking students doing projects, much like Bo's student on the hypoxic drive video was doing that as part of her internship, although she's in a residency. Best way to learn something is to teach it. And you can tell how well they learn it by the degree to which they teach it and how well they can explain it. So going on, I'm going to show this video real quick because it's going over again. It's Northwest Iowa. I did it during lunchtime, and it does a good job of recovering. I actually want you to get sick of this. The issue of excited delirium and hyperthermia. Why am I so, pardon the pun, hot on this? Regular seizures fix themselves. Rarely do people die of generic epilepsy, okay? They're not allowed to drive cars for the reason they can't kill themselves or others while they're having an epileptic seizure. And if they have seizures at home, there's probably going to be someone videoing it and putting it up on YouTube. They don't die of it. They just look scary. On the other hand, hyperthermic crises due to drugs or whatever else is a form of ultramentation that is fatal. And it's one of the things we don't catch because we don't know it and we don't think about it. We don't check it. So this is why I'm harping on this. If you brain fart on an epilepsy seizure, all right. If you brain fart on a person who's seizing or otherwise bizarrely acting, altered because of hyperthermia, you've basically created a death sentence for them.
Mr. Ritchie?
Yes.
What happens physiologically that causes patients to be hyperkalemic with hyperthermia?
Okay, I've explained this enough times that I'm going to ask you to come back and tell me why.
Yes, sir. Sorry.
No, that's not a sorry thing. I want you to, because this is like teaching it. Walk your way through and anyone else jump in and help them because I'm losing my voice.
Wait, more. What was the question again? It's something about hypokalemia or hyperkalemia?
Hyperthermia.
How hyperthermia causes hyperkalemia.
I think because since your body's gonna overheat, you're gonna lose some electrolytes. So if you sweat, you're gonna lose salt. So that's gonna lower your sodium, which works with the adverse effect towards potassium. So if sodium's low, your potassium will be high.
Okay, that's one way to look at it. So anyone else?
Is it when you're hyperthermic, the cells potentially are, if it gets really bad, they pretty much get destroyed because they're getting fried, and then the potassium inside those cells pretty much just get let out, roam free.
What do you guys think? So just to add to Martin's thing, When I'm talking hyperthermia, like when you have a fever, you clearly don't just drop dead. When you work out or exercise, you don't drop dead, even though your body temperature can go up by easily 7-8 degrees. But in the type of hypothermia we're talking about, it's damaging to the body. And it's damaging. Is anyone old enough to remember This Is Your Brain on drugs commercials, or is that way too far ago?
The one with the egg?
Yeah, what did they show?
An egg on the like cooking.
There was a
Okay,
bunch
and
of
what
them, but
was-
yeah, there was one with the
What
egg.
would the egg look like before they heated it up? An egg, right? A nice clear albumin, yolk. I'm getting hungry. All right, so you got an egg, and the proteins are natural.
Right.
When you cook the egg, what happens to the albumin, the protein?
Denature.
Denatures. Denatures means the protein gets warped. It gets changed. It's basically destroyed. Okay? And for us, that works well because it facilitates digestion and makes stuff taste good and last longer. In the body, when you cook, what happens to the proteins in your cells?
They get denatured.
They denature. And proteins are what form your ion channels, which are what regulate the flow of ions in and out of your cells, right?
Yes, sir.
Not to mention make up your mitochondria, nucleus, everything else. So now going back to the question, think about how the hyperkalemia results from hypothermia. Egg in the pan.
You become more acidic.
Nope, you're jumping all the way to the end. I want it. I'm saying you're eating and then I want to know what happens to your cells when you overheat them. I'm going to give a chance to everyone. Jarek, give me what first thing that you think happens.
If you wait, what was so like you're overexciting the cells basically?
You're
Like,
overheating the cell. Excitement has nothing to do with it at this point.
so if you're overheating the cells.
Cell is a shell. The cell controls what goes in and out of it with a semi-permeable membrane, right? It's got your phospholipid bilayers. It's allowing things to diffuse in, but it needs active transport and to get everything else in and out. How is potassium kept in the cell? Potassium channels, right?
Sodium, yeah.
And then sodium is kept out of the cell. You guys remember that from depolarization of the heart? Okay, when you depolarize the heart, the things reverse. And that's all done because the proteins in those little barrel-looking things that get the ions in and out are working, along with ATP and everything else that controls it. So if you want to think about the cell as like a penitentiary, and the inmates are potassium ions, all right, you need guards to keep them from climbing over the walls. And now you don't have those guards anymore. Where do all the inmates want to go?
They're going to go out of the cell.
Outside. So you could think of hyperkalemia or hypothermia as like killing off the freaking guards and knocking down the walls. Now there's nothing holding the potassium inside. And then, of course, inside the cells, there's also things called myoglobins, which are basically proteins. They leak out. Now, all that potassium from the heat goes into the bloodstream. Does that answer your question about the hyperkalemia?
Yes, sir. Thank you.
Okay.
Wait, so Mr. Ritchie, what's the chief electrolyte then for muscle contraction? Is it calcium or is it potassium?
Yes.
Okay.
And sodium and magnesium and chloride. They're all involved. And the cardiac one, which is the one you guys hear a lot about, let's follow that along. Where is the potassium in the heart?
Inside.
Like the rest of it's 99% of it's inside the myocyte, right?
Right.
And where's the sodium?
Outside.
And that keeps the cells polarized, right?
Mm-hmm.
All right, now all these muscle cells, penitentiaries, just loosed all that potassium into the blood, and it goes in and around the heart. Now you have a ton of potassium outside of the heart and a ton of potassium inside the heart cells. You have reduced the space between the poles, and you destabilize the myocardium. That's why hyperkalemia basically takes away the polarity of the heart and now makes everything easy and unstable and ready to fall over and go into cardiac dysrhythmia. So, Brooke Barker, can you repeat what I just said in your own words? Don't worry, Isaac, I'm coming back for you, so you better stay out of your freaking delirium.
I think I might be a little confused, but are you talking about the hyper K by the hyperthermia?
How does the hyperthermia lead to hyperkalemia? Good job, Eric Dixon. Way to go.
Basically, you said the proteins are working the cell, and like the cells have that outside shell that's going to disappear, and then that's going to cause the potassium to go outside the cell, and
Okay.
then cause the hyperkalemia.
Does that sound reasonable? In a nutshell, that's it. Okay, in a nutshell, that's it. Hyperkalemia leads to cardiac instability. How, Mr. Grillo?
It's gonna the hyperkalemia means there's gonna be a bunch more potassium on the outside, so that it's gonna be like hyperpolarized, so it's not gonna be depolarized in the right way.
Is it hyperpolarizing it or reducing the polarity, polarization? It's reducing it. Think of hyperpolarized as kept apart. Okay, if you want to break up two guys in a fight, what do?
Let them go at it.
Right?
Okay, yeah.
Arms.
Okay.
The closer you let them in, the less polarized they are, the more likely they are to get each other's face, start a fight. Anyone watch the UFC, Bellator? What do they do when they want to hype up the fight? They let the two guys get right next to each other. And it's like, ah! They pull them away again. The closer they are, the less stable they are.
Okay.
When they're really worried, they get in between them right off the beginning. Don't even let the fighters get close to each other. So that's one way to look at it. The more polarized, the more apart, North Pole, South Pole apart, the more stable the cell. Okay. So when you give amiodarone and lidocaine, you are actually increasing polarity of the heart. You're stabilizing them. And
which means you're separating them more.
You're separating the charges. Yes, you're basically separating the two parts. And when you give a benzodiazepine to seizure patients, you are essentially hyperpolarizing the GABA receptors.
Sir,
the neurons rather, via the GABA receptors.
Sir, can you also like say that it has like a synergistic effect with GABA, and it like works together with GABA to increase the like the depression of the CNS?
Yeah, it's working via the GABA receptors to create that increased polarization. Yeah, it doesn't do it on its own. It's working through the GABA receptors. So for 1,000,000 points, Terrell Smith, do you remember what GABA stands for?
Gamma.
Time's up. Brian Ferguson.
What? Don't say it. Don't do that.
No, but it starts with gamma and ends with acid.
I like that. Gamma acid. Eric Dixon's looked it up so far. What about it?
It's a gamma aminobutyric acid.
Nice.
Yeah, like
gamma aminobutyric acid.
I watched the video. That's all.
And I couldn't give you 1,000,000 points if you got it, Terrell. So that's why you weren't going to get it all out no matter what. So that's just, you basically know it means something, and each of those words means something. So gamma refers to the Greek letter, like you saw the receptors. And then you have amino, where there's a protein component, butyric, and an acid. So Andy Escalona, what does ETOH stand for? You guys hear this all the time. patient's ETOH?
Ethanol toxicity.
Ethanol. ETOH is the organic chemistry formula for ET, ethanol, and OH stands for the all part. That just means the alcohol you drink. I didn't learn that till I took organic chemistry. I was like, oh, all these years I've been saying ETOH. I had no idea what I was talking about. That was kind of cool. Let me open up this. Okay, so I'm going to watch this video, and I'm going to experiment with the audio just to see. So I need some feedback as I play it and see what works better for it. Okay, so let me share the screen first. This does a good thing too. Not everything is right, but it's pretty good.
Welcome to the Neuro
So low volume. Okay.
in service training. The approach to the medical.
Let me go to the video here.
Collaboration with the Office of the Monroe County MS Medical Director and Monroe County Law Enforcement, Fire.
Oh, speaker, save your system. Does this sound better, worse, or better, or the same?
I don't hear anything.
I don't.
Yeah, it sounds super duper quiet.
God damn it. It's so maddening. Okay, does this suck or not? Is it? Can you hear it or not?
No.
Oh, that's so fucking pissing. All right. Then I'll just have to put it as a. I'm going to flip forward. You guys can still see the screen, right?
Yes.
I'm going to flip forward a couple things. They show a lot of the same videos you've seen. And getting back to these situations. Okay, so what is essentially the definition of this kind of fuzzy condition? Anyone want to read it back? Or Jared?
Yeah. Do you want me to read it, sir?
Martin Zabala, what are you reading there?
Am I looking at the right screen? Learning objectives? Yes, no?
Yeah, we're staring at learning objectives, sir. I don't know if that's what you want us staring at, but yeah, that's what I'm looking at right now. Learning objectives.
Okay, and I'm sorry, I had the audio. I'd been experimenting with different ones. So if I missed it, that's my apology. So basically, state of extreme mental physiologic excitement, extreme agitation, hypothermia, hostility, exceptional strength and endurance, not apparent fatigue. How many of you guys have seen this in the field? What did you see, Matthew?
I remember I was with Corona riding out with them, and we get a call for this guy, and I don't know what he was on, but he was acting really crazy, saying like, "Oh, I see the aliens, like they're gonna kill me, this and that." And then my medic, he was in the cop car, and they had him restrained to the seatbelt, and I remember the medic was trying to give him Versed, and they finally got him in the butt, but he calmed down a bit, but it wasn't like anything extravagant.
What size of needle did you use? I'm just curious.
This was like 4 years ago. I want to say, I don't remember, to be honest. It was really
Okay.
hard.
Fair enough. Got some control with that. Anyone else? Yes.
I
Or
used
Joanna.
to work at the raves, And so they always
You
have.
go to the raves a lot?
No, I. And it would always be a ton of people that would overdose on MDMA or just some form of MDMA, and they would just go crazy, get really combative, agitated, take their clothes off, just all sorts of things. But they would always have a super high temperature. So in the medical tent, they would get a rectal temperature, and then they would dunk them in it's like the horse drinking water tanks. They would fill them with ice and water and sedate them if needed to.
So this is interesting. You had your medical teams taking temperatures. I'm trying to think of taking a rectal temps on a bunch of combative people. That must be fun. So cold water immersion. Did you guys ever use any sedation?
Yeah, if the person was like really, really combative, they would actually dispatch in a little golf cart like a physician, and the doctor would and they would sedate them, then restrain them, then they would get the rectal temperature in the tent.
Okay. So it's funny that the raves, if you guys haven't heard about it, the guys, those of you that don't work in San Bernardino, that's a big deal. And they used to have them like not too uncommonly. And being on duty with one of those was like kind of being on a long 6-hour MCI. It was just one shit call after another through the medical tent. So let's see if I can get the video working again so you can see that. So going on, I'm going to flip ahead there. And she covered that. We kind of covered this part here, and this ranges on the behavior. And you're not going to mistake this. It's going to be a freaking nutcase like our one guy that we saw. So if you go to prison calls, this is something, I'm going to show this little video here real quick. They don't feel pain. They don't feel heat. Everything's just wrong in them.
Without apparent fatigue. Let's be clear. This is a medical problem masquerading as a police problem. The end goal is medical management and hospitalization.
Mr. Ritchie, I think you gotta switch your screens.
God
Are we
damn
supposed to be
it.
seeing something?
Yes, I'm supposed to be screen sharing.
Not.
And let me share.
So how do
You got to remind me, I'm watching the video myself and forgetting.
They
Good.
may have bizarre, violent, or aggressive behavior. They may have violence towards objects, or binding objects. The subject may be hyperthermic or have an elevated temperature or be overheated. Oftentimes, the subject will take off their clothes in public regardless of the outside temperature. They will often have excessive prominent binding and will exhibit. This is security surveillance video from an In these next two videos, notice the bizarre behavior and loud, repetitive shouting, incoherence, and the failure to recognize law enforcement or EMS presence. You'll also notice the extreme paranoia exhibited by the individual being restrained by law enforcement and EMS. This paranoia is very common in subjects with excited delirium.
It makes my hands hurt just watching it. Okay, and I'm going to go through a couple times here. We saw our one dude. This one guy that that we saw in the video clearly, and I kind of talked about it briefly. They restrained him.
Now, relax. It's okay. Yes, it is. Okay. It's okay. It's okay. Not okay. It will be okay. You gotta calm down. Okay.
All right, so you got this patient. That patient there, he's your patient. You got him restrained, and he's acting like that. Alex Fuel, what is going through your mind? You're an EMT on that call.
Don't get punched. Make sure airways still
punch him in
open
the
and
glasses.
patent there.
You have glasses on. You won't.
What's
hit you.
that?
You have glasses on, he won't hit you.
Yeah, there you go. Just make sure that my crew is safe. First off, since he's probably got some superhuman strength going on right now.
He's restrained. Next, let's go to Brian Ferguson. What are your concerns?
I would be worried about him breaking out of those or hurting himself if he's already.
Okay, let's see, who haven't I picked on so far? Victor Murrieta. All I could see is freaking hair.
Showing off my new haircut.
Oh, okay, go ahead. What are your concerns?
I mean, I would be concerned about keeping an eye.
Can you clarify?
Am I on the wrong question? Say the question again.
John Robinson, what are your concerns?
All right, man. My concerns, I look at his vitals, his skin signs. His respiratory rate looks a little high. His heart rate's probably really high. Yeah, just mostly his vitals at that point. Wanting to just want to work on those. So probably give him that Versed. Start calming him down.
Robert Butker. Not bad on that.
Can I go again?
Yes,
No.
sure. I can't see the screen at all due to my Wi-Fi, but I would do a Versed, either IM or IN for a combative patient, if I'm not mistaken.
Okay. So I'm gonna rephrase this another way. Remember, as a medic, you want to be a little bit paranoid, not acting that way, but a little worried about what could go wrong, what's coming around the corner. So say this was a person who had, ventricular tachycardia.
Worried about
180, and they're talking to you, and you're putting them on the gurney, and they've got a decent BP, but they've got a VTAC at 180. What are your concerns?
Cardiac arrest.
What was it? You cut out.
Cardiac
Cardiac arrest. They might freaking crash on you. So what I'm trying to get at is, if I see a patient like this, he's restrained and he's hyperthermic, my concern is cardiac arrest. If he's not hyperthermic, and that's why one of the first things I'm going to get on this guy as soon as I can, axillary tympanic, I don't care, I got to get it. Temperature, and if I don't have a thermometer because I'm lame and I didn't buy one, if I feel super hot here, all right, my big concern is cardiac arrest. And if he goes into cardiac arrest, calcium's going to be way high up on the list of freaking things to give, chasing the first epi. Okay. So I ask you about what are your concerns, not about specific vital signs, because that's sort of like saying with VTAC, I'm afraid that his blood pressure might go down. Yeah, it will, like that. You should be thinking what can go wrong and anticipating problems. Let me put it a slightly different way. I'm trying to pick on everyone fairly. Christopher Fox, you go on a patient, they are got a bradycardia at 32. And the patient's otherwise mildly symptomatic, just a little bit feeling weak. Okay, what are you concerned that is going to happen as you're getting this patient loaded up?
That they could go into full arrest.
Okay, so what obvious preventive or getting ready thing would you do for this patient?
You'd want to put them on the pads.
Okay, see what I'm saying? This is what I mean by thinking preventively. So if I see a patient who's cardiac unstable, the combo pads go right on. I want to have everything ahead of the game because I don't want to be flipping through the goddamn packets on the life pack and dragging out shit and sticking it on them. I'm worried they get the combo pads. On this guy here, I'm worried that he might crunch on me. So obviously, my concern is cardiac arrest from hyperkalemia, because if his temperature goes to normal or at least low normal, the chances are very low he's going to drop on me. So how do I prepare for this? How do I deal with this problem? How do I reduce the risk of cardiac arrest in this guy?
Get the patient, sedate them, you know, with Ativan or not Versed.
Sedate them with the intention of what? Why am I sedating him? Aside from I don't want
We
to
sedate him. If we sedate him, he won't be building up his own core temperature from
That's
moving
it.
around so much.
He won't be he won't be depolarizing. He'll be polarized.
His neurons will be polarized, okay? So good. So yeah, you have all the benefits of relaxing them a little bit, but right now those restraints are serving as a heating device. They are creating resistance. And everyone knows when you work against resistance, you don't generate heat.
Yep.
I need to stop that process. And then of course, watch, and if oh shit is a concern, may follow Joanna's thing and cool them off. Problem is, cooling them off while they're fighting is kind of a race. Can you cool them off fast so they can generate heat, which is difficult to do. But if you can stop them from fighting, then everything will calm down pretty quickly, especially if they're already sweating. So you guys kind of get what I'm saying, thinking preventively, anticipating problems as a medic. You always anticipate the worst, hope for the best.
Yes, sir.
So we got basically a bunch of causes. They mention, I thought you guys might vomit if you heard this guy because he says pathophysiology and science in the same sentence. And by now you've probably heard that 3,000 or 4,000 times. So I don't have that, but he talks about the pathophys. This is kind of the loop. Okay. So you're on a unit and you get called out for PD for a pre-arrest check, the detention safety check, whatever they call it in your area. And he's got this guy kind of tweaked out. He's kind of acting a little hyper. He's locked up in the back of the squad car. What do you want to check?
Is glucose?
Glucose is one thing.
AFPU.
Temperature.
AFPU's alert. He's freaking, if he's not alert, they're not going to drag him off the jail. They'll just call you. Okay. So what is that? Who said that?
Temperature.
Always check the temp. Okay. Temperature equals rhabdo equals hyperkalemia equals cardiac arrest. It does not come back. Okay. So if they do code on you, think about it. Roll this forward one step. You get a call to the police, Alex, and they say they arrested this guy. They tased him. They've started to freaking work him, and next thing they notice he's not breathing. He's on the ground.
Let's go hook the pads up.
Okay, you hook the pads up. You see the patient's in ventricular fibrillation.
Defibrillate them.
I'm going to give you the easy one. Defibrillate him. Eric Dixon rolls up on scene, and he's like, "What do you need?" What do you do? By the way,
Me or
when I
Dixon?
defibrillate him, he's still in VFib, and he's been VFib all of your shots. So now he's fucking still in VFib.
Are you asking me what to
Push
do?
up.
What I do?
Yeah. With the story you heard, what is your next intervention going to be?
Epinephrine?
Okay. Epi, anyone disagree with that?
I would give him calcium chloride.
Well, I would do CPR, but we'll go with that. So let's get on the chest compressions. Now the protocol is pretty clear because once he's in VFib, what happens to his preload?
Goes down.
Gone.
This is shit. So you're giving the epi for that right now. Okay, mainly. Plus it's basically the law. You can't bump that. But right after you push that epi, with the history you have, what color box might want to show up in your hand as the next drug?
Pink.
I can't hear. Sorry.
You just said after we've pushed the epi?
Yeah,
Is that what you
push the epi, toss the box, run the fluids. What's next?
And the odor.
Pink box.
said?
You could do the amiodarone too. Now I'm
Right.
looking for the drug that someone already mentioned. It's an electrolyte.
Calcium chloride, no?
Chloride, because you're talking H's and T's, right?
Right. So
So
hyperkalemia. Stabilize the heart.
Don't forget to get his BP, his preload up, do the chest compressions just like everything else. Amiodarone, because it doesn't hurt either way, but for repolarization or offsetting the role of the potassium, this is one where I would think calcium chloride is strongly, super strongly indicated.
Mr. Ritchie?
Yeah.
So for this one, you would defibrillate, right? And then you would work them for 2 minutes, and then you would give them epinephrine. And then right after epinephrine, you would work them for another 2 minutes, or after epi, do you just wait for like a minute and then give them calcium chloride, or how does that work?
I'm gonna pause the recording, play. I'm interested in fixing the problem.
All right,
Copy
that, sir.
So that's not recorded, and I don't care if you record it, because I'll just say I was hallucinating because of hypothermia or something. What I'm looking at is, this is something where it's actually justifiable, and I'd be happy saying it. We got a guy suspected hyperdelirium or hyperdelirium syndrome, excited delirium. He was hyperthermic, coded on the COPS. Presumptive cause of death, hyperkalemia. Now, you're not going to see hyperkalemia because you're going to see a ventricular fibrillation. You might see a PEA, but I don't need to at that point. So epi's still indicated because first off, I got to perfuse the heart so I can perfuse the brain.
Right.
The CPR is important. Preload's important. Amiodarone, because it's written in stone. All right, I can't really get around that rule, but there's nothing to say I can't give the amiodarone and flush it with calcium chloride.
Wait, what about if I'm on internship though?
And your internship, do what your preceptor tells you. But bring up the idea. Then you might get a freaking attaboy for sneaking ahead of the curve. Hey, this guy, he's hot. I think he might be excited delirium, hyperkalemic. I'd like to give him calcium chloride. What do you think, boss?
All right, so just bring it out, and then if he tells
Bring it up, because your preceptor is not infallible. And there's some stupid preceptors out there. So if you bring it up that way, you're going to make kudos points for yourself.
Would you want to? Would you want a pressure infused line too?
I would just be basically flowing it, because fluid isn't the real issue. It's getting the med on board. Oh, by the way, that brings the idea of the humeral IO because of that rapid infusion of the heart. That's something you may want to look at. So.
Okay, makes sense. Thank you.
So I'm hoping I'm saying this again and again. I know you're tired of hearing it, but I'm doing it on purpose. I want you to get tired of hearing it. So it's like echoed in your head, like pathophysiology and the science of it. I want you to hear it in your head so it doesn't go away. There's a method to the madness. All right, so in this instance here, let me go ahead. There was another part. This is kind of designed for all EMS. I always hate watching these other counties because they have like scope of practice. You don't see this as much, but it may come back in a wave as the next group of teenagers or dumbasses try the next synthetic drug. Why isn't that working? And okay, there's a couple of things we get. You might think of ketamine, and a couple of people have brought that up as a possible restraining or chemical restraint. It's not in our protocols. Versed is, but one of the physicians talking about this, there was an hour-long lecture where he's talking about this. And the problem with ketamine is it has a sympathomimetic effect. And if you already have a super strong sympathetic action on the part of the drug, you may cause untoward problems. So benzos are the only thing that seem to work pretty well. Haldol is a problem because why?
Use of these various.
Anyone think about it? No ideas? What is Haldol associated with in high doses? Come on, guys, you just went over it last week. Joanna?
I'm not sure. Is it in high This
Heat stroke.
Dystonic reaction.
dystonic.
Dystonic reaction. Okay.
Mental disorders.
Well, it's going to zonk you out. But if it has an adverse reaction, it's going to cause a dystonic reaction through dopamine, messing up the dopamine cycle, which is exactly what's happening with these patients with excited delirium. And dopamine is a precursor to what hormone? Norepinephrine.
Norepinephrine.
Remember, dopamine gets converted to norepi and then to epi. So when we give dopamine to patients, it's basically to lead into epinephrine. So these are kind of interesting connections. All right, on the videos, that's what I meant to pull up. First off, it's been started at 15:40. Go ahead and take a break till 10 minutes from now. And we'll come back to this.
Chris, the wild man, dude.
Bro, I think you're my hey.
Oops.
One, two, three.
Mr. Ritchie.
Yes.
Have you, so when you brought up sickle cell disease, did you know that you could actually have sickle cell trait?
Sickle cell what?
Trait.
Can you spell it? I don't understand.
So it like not sickle cell itself, but like sickle
Oh,
cell.
sickle cell trait, like the genetic predisposition. Yeah.
Yes. So I guess on the chromosome, I believe, so sickle cell disease will be on both sides, but sickle cell trait will only have one side of it like that. And I was watching a video, but the only way that the red blood cell can turn into sickle cell if it's in the right environment. So you have to become like hypoxic.
Right. Did you remember me talking about that localized hypoxia?
I don't.
Okay, that's one of the issues, and I think it's really cool you're looking this stuff up, Matt. So That's where I mentioned when you have a person with a sickle cell crisis or experiencing what you think is that, and they would know, give them high flow O2. Their central sat's going to be okay, but it's at the tissue level and the capillary level that the PO2 goes down quite a bit, and that triggers sickle cell sickling. Okay, it goes from a nice donut to basically a taco. All right.
So, but what if they don't know they had that?
They don't know though. They know they have sickle cell
The
condition.
disease, right? But do
Yeah.
they know if they have the trait?
The trait, you have to be tested for it.
Right,
That's true
exactly.
for any genetic trait.
So is there a way to, I guess, like, is there a telltale sign that would, like, you'd
Yeah,
present
DNA
with?
testing.
Like, what I'm saying though is, like, you can't just go in the field and see, like, if
Oh,
they're
like you or me?
yeah.
No, not that I'm aware of. Let me get some water. So think about that as I mentioned it before, if you have someone, and typically they're from Africa, okay, or a place where endemic malaria. If they have a sickle cell crisis, this is the sort of person that you want to give them high flow O2 to produce or reduce further sickling, because as some cells sickle, they start to block off capillary flow. Guess what it does downstream? It makes everything hypoxic downstream. Now you can create exacerbation, and it's really painful. So high flow O2 to try to kind of stop the sickling crisis. And yet another reason to pay attention when someone says if their SAT's 94 or above, yeah, for most people that's fine. It is not the case for people who are hemorrhaging, people who are sickle cell crisis, and so on.
Gotcha.
Buoy.
I'll bring some water right back.
Oh, Buoy. Buoy. Buoy, where are you, Buoy? I want to see your face. Buoy, Buoy, Buoy. Oh, Buoy. Buoy. Yeah, you go, Buoy. Yeah. Hero, 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 hero. Chug, 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 chug.
He's not the one chugging, bro.
Huh? Bowie's a busy man.
He is
Much
in
respect,
a
much
different
GABA, GABA, GABA.
GABA, repolarization,
Oh.
hyperpolarization. He's in a relaxed mode.
Vasodilation.
Complete vasodilation. Histamine release to its finest. Hypotension. Mast cells going all over the place. I'm just
Wait,
kidding.
your hair looks like it's a little ruffled.
what, bro, Buoy.
Buoy, get yourself
So
together,
freaking
man.
annoying.
Buoy, your eyes looking tired right now. What's going on?
Robert, he's trying to listen to you the whole time. It's tiring sometimes.
Oh, you're so mean, bro. Gotti, why are you such a mean guy with me, bro?
It's because it's
Always.
Zed here.
Nah, look at, is that one-eyed dog?
That's
No,
That's
he
two
has
eyes.
two eyes.
It looks like its right eye is like blown out to like 4 inches.
Look
that-
more.
His right eye is
Did you get hit
blue.
in the head recently?
His left eye is brown.
Oh, that brings up a
Trauma.
question. If you get a patient with uneven pupils, what's that called? They're naturally uneven.
Starts with an A.
Very
NASCAR,
good.
like
Two
that.
glass
Okay.
Come on, Terrell, you should know this now.
Okay, I think we still have 2 minutes on break.
Anastorkia or something.
That's funny.
Scaria?
Anascoria.
Anus what?
I can't pronounce it. It's like Anastorkia or something.
Anasarca.
There you go.
Anasarca is a different condition.
Not Anasarca. It's
Anasarca is bad.
Wait, what is it?
Aniscoria.
Anascoria.
Coria.
Anascoria.
Mr. Ritchie, I was able to find that second person for that one disease about Borrelia
I saw that.
burgdorferi.
You caught.
He wasn't a guy from
everything else, but I saw that. You got the names down.
yeah, it's a guy from France. He's a microbiologist.
He's the American.
Took me a while. Willie Wilhelm. Willie was like his nickname, and then his actual name is Wilhelm.
So kind of when you're talking about that guy, what did you learn about how they name all these weird looking bugs and everything?
I just know that like with the burgdorferi, they just named it after him because he was the one that was able to link the disease to the bacteria, which was a spirochete. The way I can think of it is like a corkscrew type of bacteria.
What does spiral sound like?
And Borrelia just means like, yeah, like a little twisting.
Yeah.
I just think of it like, like if you're gonna pop like a wine thing.
Exactly.
That little thing that you just like pop it. That's the only way I think about that.
That's how they named them, like Staphylococcus and Streptococcus.
Yeah, Borrelia, like it was. Mm-hmm.
So yeah, when you hear,
the hard part was finding Borrelia because so the hard part was finding Borrelia because it would just keep popping up as like the classification of the bacteria, and that's why it was kind of hard for me to find that second person. And then like later on, if I would like read more in depth, he later on like popped out like some French guy. I was like, oh, like all the French they hide, but you know.
Well, good. You learned something there. You keep going in and out, so it's very hard because I don't know when you're stalled or whatever. But
oh yeah, right now I have like bad internet connection, so
I
yeah,
thought
so it's kind of hard to
California
like
was
follow
supposed to
along
be
with
like
you
the
guys.
king of good reception. Apparently, Korea.
I don't know.
California sucks.
Depends on the corporation you guys.
So yeah, you've heard of, if you've taken microbiology or even biology, you would know that a lot of stuff is described based on its shape or position. So you've heard of, for example, coccus, as in Streptococcus, Staphylococcus. And what does the coccus refer to?
It's the circle shape of the bacteria, right?
It's basically they're shaped like balls, cocci. Okay. Strepto means they're in chains. So you'll see literally like worms of balls. What's that game where you hang on behind someone and you freaking go through and dance? And then Staphylococcus are a bunch of balls looking like grape bundles. And there's interesting, when you look at germs, the one for beer has a name for cerveza. Believe it or not, I can't remember if it's the genus or species. And so there's lots of cool little crap out there. But bottom line, if you get to discover a new germ or planet, you get to have your name attached to it. So if you ever find a germ, Andy, it'll be the Escalona
Yes, sir.
venerealis or something like that. So anyways.
What about STD?
What about them?
I don't know about naming the drug.
If you get a new STD, can you name it after yourself?
I think they meant.
No, it has to be, you have to discover STD just means sexually transmitted disease.
Sexually transmitted disease, Christopher Bowie.
Yeah.
Okay, I'll do some
Yeah,
research.
you don't want to be the germ that's named after anal warts or something like that, okay? Yep, that's my name. So it can have a double meaning. Okay, so before we move on, Jonathan Garcia, can you describe the mechanism of action of the benzodiazepine as it regards to seizures and sedation?
Yeah. Still something I gotta hit hard.
Or just listen as it's described in class by your hardworking fellow students.
Yes, sir.
So no idea? Christopher Fox. Christopher Fox. I don't want you to freaking look it up. We're moving on to Kevin Campbell. You can see your freaking peepers looking over to the left there, the other screen.
My apologies.
It's okay, actually, if I was you too, I'd just wear sunglasses.
So GABA, it's I don't remember the ABC, what specifically each one of those do.
Make it as simple as you can then.
I just know it hyperpolarizes the cells.
What type of cell?
Neurological cells.
No, what's a neurological cell called?
Oh,
Rhymes with nerdon.
the neurons?
Yes, neurons. Hyperpolarizes a cell by GABA receptor activation. And so with that clearly put out there, Victor Murrieta, how does benzodiazepine work for your to prevent seizures?
So I'm gonna botch it, but pretty much it works by it's pretty much blocking the receptors in the brain to kind of like to pretty much release to I mean not spaz out. I can't think of the proper words for it, but it's blocking the cells in the brain from seizing.
I need tequila.
Well, sometimes, I hope you can understand this. Can you see this cool bayonet?
No.
Oh, you can't? Can you see it now? Can you see it now? Can you see it now? See it's better.
It blends in with your background, Mr. Ritchie.
Put it on your
I
like
need
shirt.
tequila.
If you turn the background off, we'll
I'm
see it.
gonna turn the background off for a second then.
I
Just
need a-
for you. All right. So you see this bayonet here? Sometimes,
Yes, sir.
and don't take this wrong, but I'm not going to stop you from taking it the right way, is
Fix bayonet.
teaching this subject is sort of like saying, point goes that way because it'll make a hole and that's the way you want to do it. And then I will go to someone and say, which way do you stab at the person with a knife? And you'll say, I grab it by this end and I do this. Over and over and over again. Mechanism of action is much like using a freaking knife, is knowing which end goes forward, or in Claymore mines, this end towards the enemy. So, learn how it works. It's not that hard. Yes, Jared Gott.
Oh, I don't actually have anything. If you were going to call
Who are
anybody, I
you
think I could
doing
answer
this
it.
for?
I don't know. I was just thinking in my head.
So
what
while
the
you're at
answer
it,
is.
tell us about benzodiazepines and how they work to reduce seizures.
Benzodiazepines hyperpolarize the neurons in the brain with the GABA receptors by allowing more calcium in and pushing more potassium out.
Hey,
And
you got all of it right except one element. Good.
wait, what did I mess up?
Chloride.
Oh, no, not
Chloride.
Let's go for it. Chloride. I said it earlier.
But if you had said hyperpolarizes a cell via the GABA receptors, that's all you really need to get to. I don't think any test is going to ask you which ion or cation you're shoveling around. But this actually came into a case. I'll tell this so you guys can be amazed and impressed. Is when an AMR medic and a fire medic were basically on the firing line. They were trying to nail them for using a benzodiazepine for a patient who was posturing after a TC. They nasal trached the patient, and the patient was just, as they put it, just totally locking up. And the medic wrote down posturing instead of writing a tonic seizure, which is why language counts. Okay. So Dr. Robert Patterson, along with some hag from REMS, were there. The doctor was there to provide muscle. The hag was there to be a hag. And they were going after this call and after this crew. I was there just to get CEs. I didn't know what there was going to be. It was just a review of a trauma call. And when they were basically asking the question, so why did you give Versed to a patient who's posturing. It was literally said like that, like to make the crew feel stupid. And REMS back then was real assholes. I mean, you get fired really easily. And they were like, they didn't know what to say. So you're ready for the bragging part now? So I was there and I said, well, actually, if the patient was posturing, that's a form of seizure activity. It's a tonic phase. And Versed would work by benzo activation of the GABA receptor, stabilize the cell. And the doctor kind of looks at me like, well, but I asked the crew, I said, but an easy way to tell if that was a seizure or not is, did the tonic activity stop once they gave the Versed? And the medics looked, they said, yeah, he stopped right away. And I said, well, then doctor, that proves that it was a seizure, because if it was anything else, the benzo would not have worked. I say this because that medic looked back, and I'll never forget, he looked back and he said, thank you. I wasn't covering his ass, I was explaining the facts. So what does that bring to this point? Sometimes knowing your shit helps, especially if you're protecting yourself and justifying your actions. So knowing your stuff. And then my boss is looking at me, Richie, what the fuck are you talking about GABA receptors? Who knows that crap? Small story about that. So know your stuff. So coming down to it, what did you guys think about the video sequence, whoever did them?
It really drove home the point of heat stroke equals hot and altered.
Okay. Did you think I was
CNS
making,
dysfunction.
Ice packs don't work.
you got the point. So I want you to see those so you know I'm not making shit up. I mean, I hope you don't think that, but in case you do, I'm telling you, it's real. And the athletics community has been the leader in this. Military has been next because of operational readiness. Guess who are the dipshits and retards of the whole freaking medical world?
Fire.
EMS. Okay. It's like they used to say, CDF, California Department of Forestry, 3 lowest letter grades you can get. Well, sometimes I feel that's what we are in medicine. Okay. Really bad. We're late. We're slow. We're lame. So I wanted to repeat it because also it keeps it damn simple. How hard is it to remember? Regardless of cause, they're hyperthermic, cool them off. The only difference with an excited delirium person is benzos is going to be your best way to get control of them. Because the worst a heat stroke will act is bizarre, but they're not freaking rabid and crazy strength people. All right. What about the GABA videos in terms of the mechanism of action, starting with that one physician and the simple things? Did the sequencing help?
Yeah, for me, it really helped me visualize and understand what happens with the whole GABA receptors, because I had heard about that, like as the mechanism of action, but I didn't really know what it meant or how it worked.
That's cool. And I learned a little bit about muscle relaxants, and I had no idea propofol worked in those. So those were interesting. I tried to build those up to it started with just basically 90 seconds. And then reinforce it and elaborate a little more. I'm not expecting you to be experts, but expect you to know that the benzo works on the GABA receptor. And I don't know what Mrs. What your farm instructors teaching you as far as how much you have to know on that, but this can't hurt. Okay, coming down to the epilepsy, tonic phase is what?
Tonic phase is the actual stiffening.
Just the stiffening, right?
Yeah.
Okay. Which brings me to the other question. A lot of people miss this. Shit, I'm brain farting on it. I'll come back to it. Going on, what's a clonic phase?
Resting phase. Right?
Convulsion.
Think of clonic and convulsion.
By twitch.
If you can't remember, think of convulsion. Clonic, convulsion. The reason you'll hear tonic clonic seizure is because classically an epileptic phase starts with a rigid point and then they go into the clonic phase. Okay, so when you're describing a seizure, they have tonic activity, which you could also think is posturing. This is tonic activity. That can be had with a cardiac arrest. That can be had when you get a concussion. It can be had for anything that can cause a tonic phase. Okay, where the difference is an epileptic will start going into now a clonic phase. And that helps when you go on a scene and someone says, I'll give you another story here, and this might help. We got called out to a seizure. And by the way, you guys are actually helping me because I hadn't thought about how much this helps until I thought about showing you. I'm trying to give you a reason to know these things. It's not just nerd shit. Okay. Whenever I go to a seizure call, I'll ask what happened, of course. And there's usually a witness because the seizing person doesn't call 911. All right. I go out there and we're at a nice house and a few ladies, and they say, Margaret over here had a seizure. Like, great. So what did she do? And the lady says, well, and Margaret's completely oriented. She's like sitting there talking and saying she's fine, about a 70-something-year-old woman. And the lady says, well, she just kind of, her eyes rolled up in the back of their head. I'm like, huh? And I said, when she stopped, did she wake up right away or was she acting all gorked out and everything? And she goes, oh no, she woke up really fast. So in my head, what am I thinking this isn't?
Seizure.
Epilepsy. It was a seizure, but it's not epilepsy. You follow me so far? But I love to have fun on scene, especially if there's kids. Kids are the best. What did she look like? Do me a favor and play act what she did. And the woman says, okay. She goes, and if I want to make her feel better, I mean, you mean like this here? She goes, yes, that one. And then she woke up right away. Yes. Margaret, do you have any history of seizure disorder? No. Bonked your head or done anything crazy recently? And meanwhile, again, thinking as a medic, I'm getting vital signs, glucose, temperature, all the crap on the side, right? I'm talking to the patient, but as Grillo and Fox and Martin know, you want to have your partners collecting the other info. You can't do everything yourself. A smart medic is a lazy medic. Let his partners do all the work. Okay. Joanna, how often do doctors do any work in the hospital?
Never.
Exactly. That's why they're doctors. They're smart. Guess who does all the work? The allies health people. So anyways, your chance of being a slob as a medic is to sick everyone else on the patient. She basically has nothing wrong. And I'm thinking to myself, what could happen next? So I've ruled out epilepsy. It just doesn't start like that. You have a history. Somewhere it starts after brain trauma, anoxia, whatever, lifelong. 2, she did not have a postictal phase. 3, she came out on her own. 4th, all the vital signs were the normal limits. And now is nervous. Why? Ferguson, can you think of why? Anyone? What else could cause her to posture like that and come out of it? That I can fix or maybe fix. Would a run of VTAC or VFib suddenly do that? She's sitting there talking. Her heart's doing this number here. Blood pressure drops. Does this. And then it starts over again. Comes out of it.
What's your odds?
I don't know. But cardiac arrhythmia, dysrhythmia, profound. There's no other thing I can think of that would do that while they're sitting there having tea and cookies. So we put her in the ambulance to take her to the hospital. I made a mistake. Huh?
Would PVCs make someone that symptomatic?
No, PVCs, unless there's one after the other, in which case it's ventricular tachycardia.
More than 3, it'd be a run of VTAC. Okay.
Well, it needs to be enough to allow the blood pressure to bottom out. Somehow there has to be cardiac forward, stop of cardiac flow. So it could be super fast, super slow, fibrillation, anything that stops the heart rate. Enough that it caused the brain to suddenly not have circulation. So the End result was, as we're driving to the hospital, as I'm talking to this really nice lady who was wondering why she needed to go to the hospital because she had no problems and she wasn't feeling anything wrong, she went into another tonic seizure. But this time I had the cardiac monitor on her. It was in ventricular fibrillation. Anticipate the worst, but if you don't think about what's happening, you won't. As it turns out, didn't do anything for her. I precordial thumped her and put her in asystole and never got her back. So it's a lesson. Whenever you have unexplained seizure activity, in particular tonic seizure, you should be thinking, why? If you got a history of epilepsy, chances are they'll have an epileptic seizure. But imagine, have you guys covered Brugada's, Wellens, prolonged QT syndrome, anything like that yet in cardiology? Okay. Imagine you get called to a baseball field or a basketball court. This happened in our gym. And it's like, oh, patient had a seizure. And you get there and the kid sitting down there is all okay. You have any medical problems? No. Ever happened before? No. Any head trauma? No. Glucose, vital signs, everything else fine? I am strongly suspicious of cardiac standstill of some sort. They stay on the monitor. And if I see signs of Wellen criteria, then they're getting combo pads on as well. Or Brugada, sorry. Why? Because I'm anticipating problems. I am thinking what could go bad now, especially if I'm not going to take two riders with me if the kid's sitting there talking to me just fine, but I will have combo pads if I see a sloped Brugada type presentation, and I'll have them on the monitor the whole way. So if something goes wrong, charge defib or sync cardiovert, whatever I got to do. And while I'm doing that, my partner's pulling over, calling for freaking help. You guys kind of follow the reasoning? I'm hoping this is making sense. But you can't think this way unless you're thinking what's involved in a seizure. And seizures epilepsy is just one part of seizures. Glucose is going to be your other big one. And untold numbers of cardiac arrests are going to be the rest. So understanding is important. Going down to the cerebral palsy. How many people watched the, what'd you learn about cerebral palsy that you did not know before, Zachary Torres? Z.
I didn't even know it was just stayed in the face.
It doesn't.
Well, at least according to like the one thing that the video that we saw, it doesn't stay in the face because it pertains to the. Oh, actually, no, I'm thinking of Bell's palsy. That's right, my fault. Never mind. I know the difference. I know the difference. I was just saying.
So, Jarek Saldivar, let me pat it back to you. When you saw people in the street, I'm sure you've seen them. If we used to have a place, we call it the Pretzel Farm, because every place there, they had CP, and they're all pretzeled up. I didn't make up the name because I'm not that witty, but we get there called a lot for seizures because seizures are common with that population for some reason. And they're really hard to work on. They're basically palsied up, they're jacked up. And when you listen to them talk or make sounds, they sound like they're retarded. They sound like they're just not there, altered or whatever. Did anyone else get that impression, or has anyone learned anything new about the mental status of CP patients?
They're mentally with it. It's just their body that doesn't cooperate.
Some of
The
them,
body doesn't cooperate.
there was that question that you had on the test. It was like, are all cerebral palsy, like, are all of them mentally retarded? But I put false and I got that right. So it's cool. But I don't know. I think the fact that it stems from, I guess, like some of them can stem from like infections, I guess, could cause cerebral palsy is pretty cool. I didn't know that.
You can have it later, but typically in utero. And remember that guy? No, it wasn't Richard Hawkins. I don't think he had CP. It's something else. It was progressive. Just keep in mind, if you have someone like that, they have a history of cerebral palsy. Okay, first off, they're almost always impossible to get an IV stick on. Okay, so if you're given meds, it's probably going to be IM. 2, talk to them like it's hard to do because you can't tell, but sort of like you're talking to an unconscious patient. Find out from the caregiver what they know, but do talk to them like they're with it, like they can understand you like normal. Because you're not going to get the facial feedback like you might expect from a normal person. Which brings me to the second part, and I put some points on it, My Left Foot. Any of you guys seen that movie? Okay, what'd you get out of that movie on this guy? On the video clip that you had? Nothing?
That like the little kid couldn't write or move, but he had mental understanding of like what was going on.
Remember, he was trying to answer the equation for his dad. Dad's a math tard too, right? You can't divide a quarter by a quarter. Yes, you can. Except he had to write it with his feet. Can you imagine writing with your foot? Okay, where's Wheezy? All right. Remember Will from last class, Fox? Yeah, his writing with his foot was better than Will's best fucking writing on any given day of the week. But that aside the point, he learned how to write with his foot, and I read about this guy when I read his book. And I was blown away. I can't even imagine. And that's why I had those pictures of the real guy there. And what an incredible story. And what that guy did for countless people with cerebral palsy was to prove that they weren't just mental retards with spasticity. They just had motor neuron lesions or damage. So that was an amazing story. So if you didn't watch it, shame on you. But the lesson is we're not all about just fixing things, because we can't fix a whole lot of things, but a big part is understanding stuff. So that comes down to that mom with her teenage daughter having the seizure in the car. What do you want to ask that mom? What do you want to do with that mom, I should say, on scene? Say you come up with that scene, Ramo Miranda, or let me put it this way, TJ, you come up with that car. You see that chick seizing in the right front seat like you saw. Mom's kind of holding her. How would you kind of approach that call?
I would involve the mom as much as possible and get as much info as I can.
Okay. What do you think, Wheezy?
Yeah, I mean, just I would ask questions and, like TJ said, involve her because it is her daughter. You don't want to separate because it would make her more worried, more trying to figure out what's going on.
Yeah,
So
Joanna. Sorry, Joanna. So in terms of using, good answer there. What do you mean involving her?
Involving her is I would literally do everything like, hey, if I was going to put a nasal cannula on her, I'd coach the mom on how to do it if she didn't already know how to do it. Because clearly the mom is used to seeing her daughter seize. So now I'm going to kind of turn it to an educational standpoint and just involve the mom for her sake and the daughter's sake. Because, all the seizure calls that I've ran, people are freaking the fuck out and losing shit everywhere.
Mm-hmm.
So see a mom actually try and work it herself. It's like, all right, cool, you're going to do most of the work anyway. So
be a lazy medic. Use your resources.
Yep. So
there's cases where the parents will spaz out, like they're tweaking, or say it's a sister. Now, in this case here, clearly the family knows this is not something that anyone's going to be surprised. In fact, that kind of makes me think, oh, what's, having a seizure? What is this regular for her? Yeah. What can I expect to see, Mom? And she goes, oh, she'll keep doing this for a while and then she'll come out of it. It's all right. Anything I need to know that is, any important stuff I need to know, what works best. I'm not even going to jump on the patient. I'm sitting there talking to Mom. I can see with my eyes the patient's ABCs are okay. All right. The mom, remember kind of on the scenario sheet, it says, what is the affect of bystanders or caregivers? Remember the top of my assessment sheet? It's there for a reason. Okay. If mom's freaking out, Mom, has you ever seen this happen before? No, never happened. Change my approach completely. Happens all the time. Okay, you tell me, Mom, what's the best thing I can do to help you out here? And somewhere in between, you'll find a path, okay? But the best way to calm someone is, one, if they're willing to help, let them help, and then put them where they can help. On a bystander, it may be simple, nothing more than holding her hand and talking to her. And Mom, it may be something more involved. You guys follow? This may seem silly. I can't tell how it impacts you when you're young. I can tell you this, as a parent and a sibling, if it's my wife or my kid, and I'm taking care of him, some dipshit medic comes over here and says, stand aside, sir, we'll take care of this. We're in trouble. Okay? We're in serious trouble. So always do your best to see what you can do if they're willing and able. I remember I kind of mentioned it before, and I don't say this again. These aren't meant to be bragging. They're trying to lessons. First or second pediatric cardiac arrest, the dad's doing CPR on the infant. He's doing a good job. He's by himself. My first words to Dad was, you're doing a great job. Do you want to stay and help us, or do you want us to take over?
Dang.
Because I know if it was my infant daughter, I would kill. So ask. You're still doing your assessment as you're walking up. You're taking in a lot. You're seeing a lot. And then you have him do something he can't, or he'll back up. But you've done him a courtesy. And you've possibly kept yourself a source of help. Just put them where they can help. All righty. Next thing. Any questions on next week? Next week we're in class. One of your tests is going to be drawing a schematic of the cardiac thoracic pump for venous return and describing it.
Is there going to be a diagram
understand
for us
it.
to? Is there going to be a diagram for us to refer to?
Yes, the one that's in your head. So if you don't watch that video a lot, you will not know it and you will not pass it. And if I have to grade your damned art, okay, it's going to be very harshly graded. There's like a whole few arrows in there. You need to be able to explain for once and for all how venous return happens. And the video link that I showed you, how the respiratory pump affects venous return, is going to be your guiding light. All right. If you do not understand that, I cannot tell it to you anymore. I cannot show any more videos. I cannot describe it anymore. If you don't understand that, you do not understand cardiopulmonary circulation. And you do not understand the cardiorespiratory system. And you do not understand CPR. You have to understand that. The good news is it's way easier than it looks if you actually invest some time in it. And by what I mean, you could learn it in half an hour if you invest the time in it. You've got to understand this, guys, at least in this school, in this class. Okay. And one day you'll go over from hating it to being glad you learned it. What did you get out of the venous return video? The first one.
Sir, when we're drawing it, are you okay with us if we're bad at drawing, if we also write like a little comment about
I want you to write comments.
Okay.
Yeah, because, oh my God, don't you feel sorry for me? I'm going to have to try to not only look at your shitty drawing, but figure out what you're saying. No, I want to see an arrow, and behind the arrow saying blood going this way. Okay, so I need to understand it, just like the video does. All right. This is not to torture me. This is an investment in you.
Okay.
This is tedious, so I want you to get it right. And once you understand it, just like Joanna says about the GABA and the benzodiazepine, your actual comprehension of what the hell you're doing will improve tremendously. If you don't get that, nothing else works. Perfusion, osmotic pressure, oncotic shit, all this other crap means nothing if you have no idea how the engine works. So you'll be better off for that. Oh, and by the way, I did mean to say that again, looking at the stack of papers I'm finishing, I can't get them off to you, obviously. I just finished the second group. I'm really proud of 95% of you for how much work you're putting in. Writing this shit's a pain in the ass. It's tough. And if you're just copying it down and writing it, you're just doing it for nothing. But for those of you that are trying, it's really impressive. And I want to say I appreciate the effort. I know it's a lot of work. And I hope, and I know one day you'll see the return on investment, but it's not going to be immediate. Coming down, eclampsia, preeclampsia. That was the other big one for today. Difference between eclampsia, preeclampsia.
Seizures.
Okay.
Yeah. The seizure part.
Eclampsia, seizures.
Okay.
One can be resolved with birth and one can come after.
Actually, both can happen after birth.
Yeah. I just thought it was kind of cool that you could have like a seizure even like 6 weeks after you give birth. And then I think the eclampsia starts from the 22nd week, and then you could get it up to the 6th week after you give birth.
And typically what ends of the spectrum of the maternal side?
Old and young.
The young, the new first time, and the older one who has a baby, right?
Yeah, it's like 35 plus.
Okay. So there's if you look further in the literature, and I'm not trying to confuse you, but I'm going to explain what I mean. Everyone you saw in there described it from a hospital standpoint. So in a hospital setting, they have a seizure, and that defines eclampsia. If you read it from a scientific research side, they will actually go as far as to say any alteration in mentation that can't be explained by a pre-existing condition. So duh, if the chick's pregnant and she has epilepsy and she has a seizure, you can't just automatically push it off on eclampsia. It's going to make things more complicated, okay? She has diabetes and she was given insulin and she overdoes it, she could be hypoglycemic, be altered Cs. So the key feature is they have a seizure that there's no good reason for it. There's no reason for it other than pregnancy. Or as I learned relatively recently, Robert, that you could have it after postpartum. That blew me away. I did not know that. A couple of years ago, I learned that from one of the nurses we had that helped us. But,
yeah, that's something that I found interesting.
So now I'm going to make it one step further. So as pre-hospital, you keep your brains alert. Imagine you get called to a house for an unresponsive woman. You go out there to East Indio and you find some overweight immigrant pregnant chick unresponsive on the ground. How did she become unresponsive or altered?
It could have been the heat.
Let's eliminate that stuff there. Good. But why I'm saying this, what if she had the seizure and she's having the seizure because her BP's gone through the roof, and in eclamptics and preeclamptics, 160 is considered the dangerous level. Regular people can tolerate much higher BP, but because of the vascular damage, they find that once the systolic BP goes above 160, it's like they are an emergency. They got to get their BP down. And unfortunately, we don't have shit for that except magnesium, which actually works really well if you know how to do it. What if she had a seizure and now because of that, she has a hemorrhagic stroke? She's not seizing, she's altered with signs of a CVA. If that had happened in the hospital, they would have known she had a seizure because she's on monitoring. In the field, you may not see that. So the point is, this is why it's on your AALU tips or turds or shit, is when you're looking at the E side, anytime I see a female and there's a possibility of childbirth, being pregnant or postpartum, okay, you'd have to ask to find the postpartum part. If you can, just consider it. I have to keep eclampsia as a factor if they're altered. They may have had a seizure and I wasn't there for it. So now, what do you expect to find for a blood pressure if they're altered? Hopefully they didn't blow out their brain completely.
Probably
High.
high.
Okay, what's our treatment?
Magnesium.
Magnesium if they're having like if you're suspecting that they're like pregnant.
If you're suspecting eclampsia or preeclampsia, give the mag.
Right.
If they're seizing and you get there, stop the seizure first, follow it up with mag.
Can they?
So give them Versed and then give them magnesium.
Just imagine what the seizure is doing to the blood pressure.
Can they have seizures before the third trimester?
I have to divide it into threes. How many normal pregnancy is what, 45 weeks, 40 weeks or so?
Yeah, 40
And
weeks.
20 weeks or after 20 weeks is when you go into that eclampsia risk phase. So yeah, you get, I guess, late second trimester. I have trouble doing the arithmetic.
By then, what I'm saying is you'd be able to see if they had a baby bump.
Oh yeah, after the first trimester, first time they're pregnant, women can hide the belly for a long time. But the second baby, it shows quick. Their body learns. They've had women, anyone know ANZA? Yeah, we've had some real shitbags literally give birth inside their spandex because they didn't know they're pregnant. Teenagers are classic that. So, baby in the toilet, stuff like that. It's unbelievable. It's kind of hard to imagine. So, going back to the situation here, if they have IV established, you should already have mag going, and it's going to be your dosing is going to be given through a drip. You don't want to push it IV. You could Brady them out and flatten them like that. Easiest way to give it is IM. Okay, imagine if the person has edema and they're overweight and you're trying to poke around for an IV access. Okay, so the protocol has a standing order that you go IM, pull it up and shoot them in the ass. The nice thing again is that you cannot overdose them with that. You will not push it too fast. You will not cause adverse reactions. You will not cause hypomagnesemia, hypermagnesemia. It's titrated right there.
And just to confirm, you're talking about Versed still, right?
If they're actively seizing and you don't have IV access there, stop the seizure first. It's like a hypoglycemic. If they're actively seizing, stop the seizure because that's happening here, guys. So if you want to think of seizures as like neurons treading water and drowning on the last little bit of air they can get as they're seizing, you want to relieve that first. Then, of course, the definitive treatment is to get the glucose fixed in the hypoglycemic and in the lady, because the vascular effects of magnesium is what you're looking for, give them the magnesium. If they're seizing, stop the seizure. The only exception is if you already have IV access established, then sure, go ahead and push your dextrose or mag because there's no difference in time. That makes sense? So it's something that's not spelled out. It's already been printed and published and compared in the literature. And again, it's something I had to actually be untaught. I was always check the glucose first, give the glucose. And I was forced to reappraise that when they found there was an average of 6-minute delay while medics fucked around trying to get IV access and said, stop the seizure first. You're trying to protect the brain. The body's going to be okay. The Versed is to protect the brain. Remember that. Versed is to protect the brain, or benzos. Okay, so
real quick, sorry.
Yeah.
Would the route for Valium? I'm sorry, Versed. Would you give that deltoid, or would you go with the
whatever I can get.
Yes, sir.
The nice thing about the nice thing about the butt. It's all depending on what position they're in, right?
All right.
Imagine them lying on their back. So, well, I can't really show it, so you have to grab your own butt. Put your hands on your butt cheeks like this. That's accessible. Your lateral and your high It's pretty easy to stick the needle in their butt cheek right there, no matter what they're doing. You can stabilize it easily. You don't have to worry about hitting any nerves, and you're going to go into a large muscle. And yeah, you need to go in the butt because you're given a fairly large amount of fluid with the magnesium. It's going to be 2.5 cc's to 5 cc's. I know the book, they reduced it to 2.5 cc's because they chickened out, but they started at 5. And then nurses got scared because they're not used to giving that much, but you can give 5 IM, no freaking problem, guarantee. Documented as 2.5 cc's. That just means you have to drop twice as many syringes and pull it up twice. So your biggest fear of mag is if you push it fast. I know because I tried it on myself once, I almost knocked my ass down. Push an IV is like, holy crap, I almost fell over. It's that sensitive. And you guys that see me do nitro doesn't do shit to me. Mag, oh yeah. So don't push an IV because you can stomp someone. That's why you'll learn in your magnesium all the contraindications, bradycardia, hyporeflexia, hypotension, because like giving a calcium channel blocker. So if it goes in IM, no worries. If you give it IV, you have to, or IV, you're going to have to set it up in your little 50 cc's or 100 cc's and run it over 8 to 10 minutes.
So mag, preferably IM. No,
that's
IV.
what I would do. It's fastest, easiest way to give it. Again, imagine this. You have a seizing patient. I have one eclamptic patient in the hospital. It's kind of funny because the nurse practitioner is in England. She's lying there and the dude's assessing her and he's doing all her deep tendon reflexes and crap. And then she starts flopping on the table. And this poor guy has almost looked like, and they call him a midwife, even though he's male. So he's flopping around and she's flopping like, oh man, he's like going back and he's like not sure what to do. And he's just kind of going back and forth, help. So that's it. And it is scary if you're on your own, especially in a setting where you don't expect it to happen. So if you got it, the easiest way is IM because it's just fast. And with that volume, you want to give it glucose in the butt. So you can give it in the thigh too, but only if they're unconscious because thigh, that'll feel like a knot. That's definitely like knuckle punching someone in the quadricep. So any questions so far? I'm trying to think of if I missed anything coming down the list. So
I just want to clarify for the venous return drawing. Do you want us to draw you want us to draw the heart, but do you also want us to draw like the diaphragm and like the whole rest of it, or?
Oh, okay, so I'm going to show you here. Let me show this to you because again, good question. And I want you to be clear. And since no one's watched this for a while, let me go back a second. Let me get to it here. Okay, so stand by.
This was our daily walk before we tried the Joyride harness.
Downvote. Skip ad. No, I get no money from the ads. And now, God, if I got money from the ads, I'd share a lot more videos. Okay, so watch this carefully.
Venous return is the flow of blood from the periphery back to the heart's right atrium. Blood from the upper body returns via the superior vena cava.
Yeah, we don't see nothing. We can't see it.
Stand by. Is it not showing?
No.
Okay, let me try again. Hold on. I've got 4 screens. So now do you see it?
Yes, sir.
Yeah, I see it now.
Apologies.
The flow of blood from the periphery back to the heart's right atrium. Blood from the upper body returns via the superior vena cava. Blood from the lower body returns via the inferior vena cava. The rate of venous return is determined by 2 factors: the pressure gradient between venous pressure and right atrial pressure, and venous resistance. A decrease in right atrial pressure leads to an increase in venous return.
Okay, I'm going to stop it there just to kind of step through this because this is easier digested in bits. What is she saying right there about right atrial pressure?
It's less than the regular venous pressure.
Okay, good. So if the pressure in the right atrium is less, what does it do to the blood that's higher pressure in the venous system? Sucks it in, right? Like that. Can you see that? Now, what can decrease right atrial pressure? Expand the chest. Okay, if this is my right atrium and this is my chest, right? Just like the pleura in the lungs, as the chest expands, it allows my right ventricle, right atrium to open up better. Can you see that? It's that simple. And the pulmonary circulation side is something I just got. I'm embarrassed to say. I'm not very smart. This is why I have to kind of understand crap. Okay, so I'm going to continue it on. One step at a time, and you'll see how easy this is. Then you'll wonder why you waited so long to do it.
And vice versa. Breathing is one of the mechanisms that facilitate venous return. This is known as thoracic pump or respiratory pump. During inspiration, the diaphragm moves down, expanding the thoracic cavity, resulting in a decreased intrathoracic pressure and a subsequent expansion of the lungs. Part of this change in pressure is transmitted across the walls of the heart, lowering right atrial pressure and thus facilitating venous return.
All right, anyone take a look at this carefully. You'll get, the more you see this, just like Robert shared that video about the PaO2 and all this other stuff, you're starting to get familiar with this terminology, which looks confusing, but you're realizing it's a way to describe things. So you saw how it's PIT. So I'm sorry, let me go back so you can actually see the screen itself. See how the pulmonary intrathoracic, right, pressure. You have the pulmonary RA, right atrial pressure. It's like coding. And you have VR for venous return. As the pulmonary intrathoracic pressure drops, what causes that drop? Breathing in, right? Chest expansion, diaphragm dropping because of negative pressure inspiration. Breathing, right? As it drops, what happens to the pressure in the right atrium?
It also drops as well.
Right. Why? Because it's getting pulled open or closed?
Getting pulled open.
Pulled open, right? And remember how low the pressure is coming in here? So we have a central venous pressure that's really low, and that inspiration helps facilitate charging of the right atrium. It increases preload. Follow me so far?
Yes, sir.
As it increases preload, what happens to venous return?
It increases.
It increases. And now, if you get more blood and venous return in a healthy heart, what happens to your stroke volume then? It's got to go up.
Mm-hmm.
I say in a healthy heart because in the case of pulmonary edema, where the left side of the heart screwed up, you may actually want to reduce the amount of blood coming in. And that's why we have PPV from CPAP to reduce that venous return. Can you see that? Anyone not get that? If I was blowing in air through the trachea, what do I actually do? I'm compressing the right atrium. I'm forcing everything down. And now my venous return decreases because my right pulmonary atrium went up.
For positive pressure?
From positive pressure.
And then
Remember, how you breathe is you expand, like pulling the plunger of the syringe down.
And then we're decreasing the CVP as well.
CVP is going to be decreased when you, well, actually CVP may be the same, but you're overriding it now.
Okay.
So I'm going to continue play again.
Another aspect of the diaphragmatic descent is the concomitant increase in abdominal pressure. As the inferior vena cava passes through both abdominal and thoracic cavities, an increase in abdominal pressure together with a decrease in thoracic pressure squeeze the blood upward toward the heart.
Okay. And your CPAP. Oh, don't forget to remind me about next week, the CPAP thing. When you take a deep breath in, what do you do to the intrathoracic pressure? You reduce it. At the same time, which is concomitantly, you're squeezing the abdominal compartment. Can you see how you're literally pulling the blood back into the thorax, into the right heart?
Yeah.
Aren't you saying something, I think last time when we met on Saturday, about like the toothpaste tube, how like you put more pressure at the bottom,
yeah,
and the base goes up to the less pressure, and that's basically what's going on right here.
Yeah.
Diaphragm
You are
breathing.
squeezing down the diaphragm, and it is pushing it up that way. It's like creating an escape route. Okay, I push down on this side. Well, the blood has to go somewhere. It's going to go up there. And I just happen to step aside to let it go right past. Okay, this is again normal breathing.
On the other hand, left ventricular stroke volume is decreased during inspiration. This is because the expansion of the lungs causes pulmonary blood volume to increase and the blood flow from the lungs to the left atrium to decrease.
This was new to me. I had not thought about this. I want to back it up a second.
Blood volume to
What's happening as you're sucking blood in and the right atrium's preload is improving and the right atrium is pumping more blood in? As the lungs are expanding and these blood vessels dilate, does it make it easier for the right side of the heart to push blood into the lungs? Thais, can you see that? The lungs are opening up. Within the lungs, as they open up, these get wider. You're increasing the vascular system, the width, you're venodilating, if you want to say, dilating the blood vessels in the lungs. They get full. So while they're basically getting more blood in them, now it's actually reducing return to the left heart slightly. Remember, this is per breath. Okay.
increase and the blood flow from the lungs to the left atrium to decrease. During expiration, the diaphragm moves up. The pressure in the thoracic cavity reverses. Venous return decreases. Pulmonary blood vessels shrink, pumping more blood through the pulmonary veins into the left atrium. Stroke volume increases as a result.
Any problems following this here?
Stroke volume increase.
Can I say one thing about the left stroke volume? It says on there, right?
Mm-hmm.
When you breathe in, your left side of your stroke volume goes down, and then when you're breathing out, your stroke volume goes up. Is that correct?
Because this pressure now goes back up. Remember intrathoracic pressure?
Yeah.
It comes back up. So now it's kind of pumping the blood out of the lungs into the pulmonary vein. Okay, that increases the loading into the right ventricle or left ventricle, increases stroke volume. Right atrial pressure increases. It's basically shifting it. That's why they call it a two-stage pump. They're kind of doing this back and forth. Now, I just kind of walked you through this to show you it's not as difficult to understand as it might look at first, but you'll have to watch this a few times. Okay. Really want you to get this concept. This is like almost fundamental in more ways. Believe me, what I'm telling you now, what you're seeing is like about a third of the issue. Then all you have to do is figure out what goes wrong when you do PPV. And what if something goes wrong with the right side of the heart and the left side of the heart? But if you don't understand this part here, none of the other crap is going to make sense. You're always going to be stuck trying to memorize shit. So, and this also, by the way, gives you an idea for at one point they were doing CPR. Let me stop share. Where they were doing one person on the stomach, trying to go in the upstroke. It was like literally kind of seesaw compressions to try to improve venous return.
So just to confirm, basically on normal inspiration, so venous return increases, right? And then everything else decreases. And then upon expiration is vice versa, right?
Just draw those pictures. You'll probably need 2 pictures, and you could do a rough schematic. Okay, I'm not expecting you to have like massive, artwork. That's not the point. The point of the artwork is so you can spell it out, but it's not something you can really write well. It's easier to say, okay, this is what's happening. You could show one artery, one vein, just like this picture does here.
Do you want us to include the blood flow from the legs as well?
The blood flow from the legs is inferred by the inferior vena cava, but if you haven't watched that the video, watch it, because that blood flow coming from the bottom, the blood flow getting from the legs to your abdomen is what? Is driven by what?
Valves and twitching of your muscles.
The valves are what keep it from backflowing. The muscles are what push it forward. You guys know what do they call it? The veins in the legs popping all out, the valves are destroyed and everything like that. I've just been funny. Those veins. And what are those typically associated with?
Clots.
Standing a long time, not moving. Genetics is a big part of it. But the valves fail. And those valves are broken. So what happens? The blood stays there and starts to stretch out the veins and makes those discolored veins. So this is where exercise, walking, moving really affects. Now, those are superficial veins, right? The deep veins, there's plenty of deep veins and bigger veins inside your calves. And those are what get moved. And that's why walking is such basically a fundamental thing. It kind of gets the blood up out of the legs into your thighs and from the thighs into your abdomen. Once it's in the abdomen, it gets pulled up by the respiratory pump. But if you think about it, when we talk about someone standing still and locking their legs, why are they passing out? Because
it's reducing, I don't know, it's reducing the preload because it's not getting back to the vena cava to come back to the right atrium.
Okay, it's not getting out of the where though to the abdomen. The vena cava starts in the abdomen, so it's never even making it.
Yeah, it's not getting out of that. What's the cavity behind the knee, behind the patella?
The knee?
Oh, yeah.
Okay, what is the vein? What are the veins coming out of your legs that join up to make the inferior vena cava?
Like veins?
Femoral vein?
Femoral vein.
Oh, okay. Well, yeah.
Is there a popliteal vein?
So you have the popliteal is an artery, and they may have a popliteal, but they all come together though. I'm saying popliteal artery is the division of the iliac artery. Okay, second most common site for aneurysms in the body, besides the aorta. Yeah, I know that. I found that out too. That was interesting. So anyways, your calves are what push the blood from your ankles and legs up to your thighs. The combination of those two get it up to your torso, and your torso is where the inferior vena cava is. Once it's in the torso picks up with that cardiothoracic pump. And if you stand still all the time and your leg muscles aren't working, guess where the blood can't even get up to? Can't get out of the legs. So now you don't have venous return to the vena cava. So if you're not sure about that, watch that video again. Those are the valves, and that's why they're important. That's why we have them. And that's why people fall out when they're standing. And they also get clots and DVT when they're sitting forever. It's in the video. These are short videos. These are for you, not for me. Okie doke. So I'm going to wrap this up here. So we have CPAP testing next week. What I've done is redone the endotracheal tube and King video. And so this is going to leave you a choice. If you like to do the skill under the original video on the original skill sheet, that'll be up to you. What I've done though is take that skill for intubation and the King airway and make them nearly the same, starting off with basically a simplified, your basically check out of your parts, have the intubation to do the intubation, whatever you're doing, secure the shit, do the steps you need to do to check it. But then the questions will be like, what about this? What about that? What about the other thing? Okay, before it was a little bit difficult because you had to think of the questions before and after kind of. So I want to make it to where you could just focus on doing the skill like you would do it in real life. You're not going to stand there on an intubation case and run down a list of fucking moan, be fast, lemon, malampati, hair color, jaw size, age, fat, teeth, no teeth, mouth size, and 3 grips. Nothing, none of that shit counts. Okay, when you get
that's what
intubation,
Cassars wants us to do though.
you don't ever do that in the field because you'll never get intubation in your life.
Okay, so just basically ignore what Cassars is
I want
saying.
to make sure that you listen to me, Robert. This is for field intubation. This is not digging on Casares. What he has done is a really good thing because anesthesiologists, it's a really high liability job. They chip the teeth. They cause a person to lose their voice because they damage the vocal cords. That's like instant money lost. So they're real paranoid about letting medics coming in there and bludgeon, not just medics, believe me, medical students, anyone else. They don't want to trash your patient because it's not something they could say, oh, don't do that. It's more like, oh, shit. Jack them up, okay? So this is why what Mr. Casares is saying is really important. He's trying to give you credibility. If you're going to fit in the world of nerds, you need to sound like a nerd. When in Rome, be Roman. So if I was going to go do my OR rotation, guess what? I'd want to sound as smart as I can. I can do probably as well as the most anesthesiologists. But if I got to get their approval for them to let me put my hot little hands on the intubation device, I need to impress them with the fact that I've done my homework. So he's teaching you to do that. Make the right noises. Oh, look.
Right, but then
I think also it's a really just quick visual thing, like something you see and you do in seconds. Like you're not going to be sitting there reciting all the acronyms right before.
Right.
They never do that. Even they don't do it. But think about this. When they're doing the intubation, and thanks, Joanna, they've had this patient on a mask. They have them pre-plumbed. They've got to secure everything. They've got high flow too and a spontaneous circulation. They could say take to 4 or 5 minutes to intubate this person with a healthy person. If they're in shock, they got a lot less time. They have that option and it's a controlled environment. So this is what Mr. Casares is teaching you, is how to be good for that. But even in the ER, and I'm sure Joanna, you've seen it, if you guys have seen the field, when the ER doc's intubating someone, how is his intubation once that person is set up? It's pretty much in and done, or they back out. So going back to the skill, the reason the original skill sheet is wordy, I'll tell it to Chris and Martin because they were there, is because I was trying to basically do a compromise to keep Mr. Casares happy, because the original skill sheet had like everything in it. Mine has half of the number of things in it. I was like, Steve, no one's fucking gonna remember this shit on scene. No one does this on scene. Well, they gotta know this for the OR rotations. Okay, I got you. So that's why you heard me ask them in class. I said, are you going to go over this before they go to rotations? Because it will help you in rotations. You don't have to be smart. You just have to sound smart.
Yes, sir.
Okay. So all I care about when you're in the field, all anyone cares about is that you find the right hole and you manage it afterwards. Okay. Something like that, Beavis. All right, good. So anyways, so with that in mind, the skill is meant to simulate more of an actual field call. You have your tube, you know, basically your contraindications out of the way, place the tube, and then once you've got the steps out of the way, now you just have to know the answers to the questions, which is much easier, and you do need to know in terms of your ventilatory rate, pressures, and so forth like that. Make sense? So that's the next skill sheet I want to get out there. I needed to make it user-friendly because we just kind of went way too much to the geek side. And I love geek stuff, but don't let it get in the way of being effective. You have to first accomplish a job. And that's pretty much it. So with that in mind, airway testing next week is just going to be the CPAP and know how to set up the NEBSET. You guys have done this enough to get it. That means that it'll be the week afterwards, week 11 to 17. I'm going to push the needle, crike, and nasal trach scenario back. And then you guys are going to do the King airway and the oral tracheal intubation. So that's going to be on November 4th. I'll upload that onto the syllabus. So CPAP for next week. That'll be much more common than your intubation skill. King airway and endotracheal tube for November the 4th. And then we'll push your crike and nasal trach. Crike is really easy once you kind of understand it, onto the following week, just basically shoving everything back 1 week. Okay, so please don't make a lot of retests because it's going to be freaking in December.
So would we be doing our midterm first and then the skills?
I don't have a midterm. All your tests are midterms.
Okay.
You have a 1/17th term and one fucking 2/17th term. Every week is like a little bit of a test. But pulling up for the final is going to be a mix of questions from every week.
Gotcha.
Okay. Remember, we're not passing the test here, trying to build on what you know. And you guys got to understand that whole part about, I wrote that post about trying to minimize the amount of crap you're remembering. It's like shopping when you leave your bag in the car. Does anyone do that? Thank you. It's like self-limiting, right? If you don't want to buy a bunch of shit, leave your bags in the car, don't use a shopping cart. You're doing like this number here. Okay. The more crap you remember, there's only so much stuff you can remember. So the better you understand what you're doing, like understanding why benzodiazepines work in seizures, hyperpolarizing the neurons via the GABA receptor activation. It's like done. I don't have to remember that. I got it. I know what it does. It's like that's what you want to get to. And that's when you saw me assess the patient the other day, when TJ tried to screw me all up, give me a fucked up presentation on a non-existent PE patient. All right. How many questions did you see me memorizing and asking? How much did I look like I was memorizing steps?
No.
What did it seem like to you?
Seemed like none, not really.
It was just natural. It was like.
You're talking to a guy who still can't remember his H's and T's. I have to think real hard about him. But I do know what I'm looking for. When you get to that point, guys, your assessments are not stressful anymore. When you know what to do, it's like having a baby and you've changed his diapers the 50th time versus the first time. It's like, I got this. First time, you're trying to remember which way to put the diapers on. Okay, and you're stressing out. 50th time, you understand it. What you want to get to is understanding as much as you possibly can. Then you will just be doing what you need to do on scene instead of trying to remember shit. So thanks for all your hard work. For those of you that did it, good for you. And you could tell. Even when you screw up, you could tell you were doing the right thing. And it's really good to see. One last little thing. When I'm grading papers, this is what it kind of sounds like. Oh, great. Oh, great. Oh, great. This is awesome. This is awesome. This is awesome. But then some papers is like being a Dallas Cowboy fan. Oh, shit. They won the first quarter. They're heading the second quarter. They're in the third quarter, but it's a Dallas game. Fuck. They like run the ball backwards and snatch defeat from the jaws of victory again. Massive disappointment.
And that's like the Dodgers every postseason, though. They always choke.
Oh, no.
Hey,
Just being an Angels fan in spring
This is-
training.
When I grade the papers, when you see a lot of red on it, it is not a sadistic thing. If I was sadistic and I wanted to see you fail, I'd be fucking 10 sorts of asshole. I shouldn't be in this position. I'm actually cheering you on. But when I see you crash, there's literally like, fuck, real disappointment. Now, when it's something like VZ crashes where he spells something wrong the whole way through, I'm like, all right, I get it. He knows that he just freaking brain farted all the way through. When it's someone that I could tell they clearly didn't look at the material, they're just guessing their way through, it's like being a Dallas fan all 4 quarters. It sucks. So I am rooting for you, but I can't do it for you. So, all righty, long day. Thanks for your time. Sorry about the stupid volume and the, what can you say? You find a solution, let me know. So see you next week.
You,
Mr. Ritchie.
Thank you, sir.
Good
You have a
night.
nice-
So assessment?
Mr. Ritchie, real
Yeah.
quick question.
Can you go through the whole full mega code right now?
Oh.
No, I'm just kidding. My brain is fried. I can't.
Mega
Mr.
code
Ritchie.
is so easy, except what you're trying to think of all the little differentials. But yeah, anyone you want, I'll be here now to as long as you got questions or whatever.
Mr. Ritchie.
Yes.
The videos for like our own personal videos of explaining stuff, I emailed you them on Wednesday because I did the whole Canvas screw up thing.
TJ.
I was curious if you got them.
Okay, so yours I have, there's about a third of the videos I have to go through. And I haven't gone through those because I had to get this stuff first.
I'm just making sure that I didn't mess up
see on
again
Outlook,
somewhere.
Jared. Did you send it through to Outlook?
Yes.
Let me double check.
Yes, I did.
Real quick. Jared is Melendez? Which one? Got you.
Melendez and Gotti.
Wait, that was quiz on my life. Video assignments got Jared, and you had 3 assignments. Yep, I got them right here.
Melendez,
Right
you
on.
look like a doctor, bro. Those glasses.
Actually,
Okay, cool.
Jared,
Yeah.
you look like you could be. You look like an intelligent guy. So
I think he took off, so he didn't hear it.
So he actually looks.
We were talking about Gotti, obviously, not Melendez. Screw that guy.
Damn, I'm gonna have to buy some. I'm gonna have to buy some glasses. Know that do something for me. I'm just kidding.
I have to grow a mustache now.
I can't grow a mustache. I thought I shaved it off. There were people were making fun of me for it.
Yeah, that same problem I had. I tried to grow a mustache. It wasn't fun. So
Yeah, that's a no go for me.
To be honest, like today was a long day.
Today was amazing. Thank you, sir.
every day is a long ass day, believe me. But I feel for you. I know it's a long ass day. And that's why, again, it's trying to like, I don't have any good answer for you except to try to learn the stuff well, because I know it's a lot of information and it's going to overwhelm you. And the more you're trying to memorize it, the more it's going to overwhelm you.
Yeah, no, definitely.
So your easy.
I think I just have to go back and look over it, and then
you're doing the right things. Try to use, if you're working out, again, those audio books. Does a PathoPhys have an audio component to it or not? I don't think it does.
yes, but it doesn't work.
It's not that great. It's not user friendly.
Oh.
Registered Nurse RN is good. It basically is the patho book in a video form.
Yeah, pathophysiology is just pathophysiology. It doesn't really matter what text or small little details. So that's when I was trying to do electronics and it was really hard. It was like I didn't understand any of it. And the worst thing was all memorization. I would listen to it over and over again. I don't know if it worked in sleep, but I listened to it in my sleep. It was an obsession. It literally has to be an obsession in some ways. You've got to do nothing but think about this course, about this class, about this stuff. And electronic school was that way, 5 days a week, every night for a year. It's 13 months.
Yeah, that's what I'm doing right now. Like, just watch random videos, review.
Yeah,
I probably didn't get a good night's sleep last night. That's probably why too.
And Robert, I could tell a lot with when you say stuff, it's evident you're learning. And now you just have to integrate it. But it's just like learning a language. Every time you kind of practice a sentence, practice a theory, practice a thing, it's like saying, ¿Dónde está la biblioteca, Pedro? And then I understand the answer and keep doing it and keep doing it and keep doing it.
No lo sé, está por en otro lugar.
Exactly. So patient assessments sound like. What? What'd you say? So I'm assuming you're not staying on because you have nothing else to do. So I'm here and waiting for whatever thoughts you got.
I actually had a question. So, oh, you can go.
Go ahead, Mr. Weesey. I'll ask after.
Okay. For that my left foot, it said that there was an assignment due, but that was for like December. Was that a typo?
No, that was on purpose. Which my left foot was to give you time. So it's kind of like an extra credit thing. That's one of the few softy things. And because I think it's really important that when it comes down to it, you're not just a technician. You are providing a benefit to people. Like the whole talking and sweet talk shit. It's like, I used to think very little of that when I started. I was kind of out of the military and everything was hardcore. The longer I do this, the more I realize how you make people feel counts for everything. But if you don't understand them, you really can't approach them. So my left foot is like a step into especially if you work around Loma Linda area, anywhere in Loma Linda area, you'll see CP patients a lot. And it really helps me to know that this person is with it as opposed to just comatose and gorked out. It's why I covered the Guillain-Barré patients. Not that you could do anything different, but I can hardly think of a shittier place on earth to be than paralyzed in my own body with no one even knowing I was there and treating me like that. So you guys know if you run on that patient, you'll be able to treat them like a human being and make their day a little bit better. Those are the reason for those.
Okay. And then also one more it's the same, pretty much the same thing, but would you prefer us turning it in closer to December or
I don't care.
Okay.
Whenever. Do it when you can. It's pretty easy. It's actually really easy. If you know how to do any research at all, it'll take you freaking 5 minutes. But if you're an internet tard, it'll take you 15 minutes.
It took me like 2 minutes. I did it on lunch.
Yeah, it's like garbage points. It's so easy. It's like a shame on you if you don't do it. So,
and it's
the questions. Yeah, the questions are pretty.
I found that out in like a minute. It's easy to do, but different people have. Yeah, in effect, it's not extra credit, but it's 20 points, I believe it is. So it's a pretty significant size. I can't put extra credit in the program. I already looked how to do that because that was what it was going to be. But Canvas does not allow a EC thing. The way they said to do it is basically make a bogus assignment at the end and then just slap it on some other place. So I can't do it and trust myself remembering it. So it'll kind of depend at the end of the semester, depending on how things go. I have some leeway, but I have to basically delete like a test and kind of transfer the points over. I'm not saying I won't do that. It's going to depend a little bit on what your guys' effort is.
Okay.
So
going back to the video, so you don't really know 100% which ones weren't sent to you yet?
I know that I've got from Jared Gott, move my cursor over here. Oh, that's his own name. I got a number of them. So the ones that aren't graded, TJ's score dropped off. That really pisses me off because that was one of the first weeks I did. Go to my inbox here. And I apologize. I've got like freaking stuff. Do you guys get emails from the college too and everything? Yeah, so you get all that crap there too. So I've got Escalona. Are you still there? No,
Yeah,
yeah,
thank
you
you.
did.
Yes, sir.
You copied and pasted half your shit there, didn't you?
Or which one? The cerebral palsy or
Let me see
the
if
research?
let me see if this sounds like Andy Escalona writing. Ready? You guys give me a vote. Thumbs up, natural writing or not. Nasolabial fold is common wrinkle that forms alongside your inner cheek, also known as the smile lines or laugh lines. Bell's palsy causes the nasolabial fold to disappear by paralysis of the facial nerve due to dysfunction of the seventh cranial nerve, which it's actually looking at all the grammar errors. I'm thinking you actually did write that. Did you? It's too many of them. Okay, good. All right, so I take it back. All right, I got Saldivar, got him. I thought I graded yours too. I did. Boatger, is yours not online still or not? Nope, not there. Barbers, got yours. They're scattered like over 1 million freaking emails. Visa's got yours. Joanna's got hers. I know I graded hers. So if I don't got those, I'm going to go to the rest of the videos tonight just to get them out of the way because they're just hard to track. Let me know if yours aren't up. I know if I've seen them before and people have sent them. So it's just, I'm just getting mixed up between different assignments and various emails and shared links. So I promise you this, you will not suffer a hit on your grade for a mistake on my part, an administrative issue, a failure on Canvas, nothing. That will not happen. You guys see that by now. Okay, I'll always give you the benefit of the doubt.
Thank you, sir. Well, just let us know. I told you before how much I don't trust technology, so they're still on my phone if you ever need them.
Yeah, keep them because I need that, but I want the send date to be somewhat legitimate too, because it's irritating to me. Imagine it spends a lot of time grading it, and it's like, what happened? It's like putting money in the bank and it disappeared, and it's not a manual input error. It's like you save it and it goes, but I don't even know where to go to fix that, so I got to just re-enter them. So yeah, it's a headache. And it's for me, it's a headache. For you, it's a headache. I just don't know what else I can do about it. So,
I wanted to let you know that I got my name changed, but I wanted to make sure with you
oh,
that it's
good. Because I keep looking for you by your address, but your email. Speaking of which, my application to chiropractic school, one of the schools from Pennsylvania put the wrong one on my transcripts. So this morning I was actually doing the same thing, is getting them to fix my transcripts. And yep, there you are. Matthew Barber, second spot. Good. Now easy to find. Thank you.
Of course.
Mr. Ritchie, just wanted to clarify for the next week's test, is it going to cover Chapter 18 or will there be an online test covering Chapter 18 before next week's test?
There'll be an online test. You know, Mr. Casares gives you kind of your test is like, I guess, Wednesday afternoons or whenever.
Yeah.
So I'm trying not to do that because I know people have shifts, but I also knew that there was kind of a pile up of stuff happening. So I don't want to give you just 1,000 tests. That's not the way to do it. So it's going to be an online test, but it's going to be due by next week. But it's just basically, again, touching up on your reading because the neuro thing is just super important. I'm not really concerned about the minutia and obscure diseases and crap like that. It's more to get the rough concepts of the things we cover today. For example, I don't cover ALS because I don't give a flying fuck. There's nothing you can do about it. Okay. Lou Gehrig's disease, cerebral palsy. The only things you had on those is essentially kind of look at what's to recognize them so you can deal with them if you see them. You know, and for example, Bell's palsy to get the difference between it and a stroke because that could confuse you. Cerebral palsy so you don't treat them like an inanimate object. So I'm kind of focusing on the stuff that you can deal with, the seizure disorders, ICP issues and things like that, because those are things you do run and that your knowledge of those makes a significant difference in outcomes. I hope, and please don't tell me yes just to make me feel better, but I hope that the things that I tell you like knowing the mechanism of action of a drug, or like how a seizure ends. So I could tell, oh, it's not an epileptic seizure, but it's some other seizure, like that cardiac arrest chick. That you're getting the reasons for these things. They're not just for knowledge. They're there to make a difference in how you manage a call, how you recognize problems. Are you seeing that or not?
It's like you said, and Miranda, you can attest to that too, because remember you were asking about systematic way to progress through your H's and T's. Well, if you know the MOA behind that, we don't really need to have a list in our head.
Yeah, that's the best idea I can give you. You could construct it. H's and T's are like AALU tips. They're there as clues, like ABCs, but you don't necessarily operate that way. They're, again, a checklist to kind of make sure you don't forget, because none of us thinks that way. But if you've seen the calls enough, like the seizures or whatever, you start to keep those in mind. Now you can connect why a guy coded because of a meth overdose or a hypothermia or a heat stroke. Because, how old are you guys? How old are you, Ronald?
I'm 30.
30? Escalona?
22.
22. Isaac, you're still young, under 25, right?
22.
22. Brooke?
22. I'm older than I look, I swear.
All little kids. Okay, I expect to see you with a little bag and a peanut butter jelly sandwich in there, okay? So, anyhow, is when I gave this talk to REMS about temperature check-in and hyperkalemia and thermal arrest, and it was blown off by the medical director. I was really upset about that. Because in that month, do you guys know Leah again by any chance? She was the primary PLN at REMSA, and before that, she was at Inland Valley Medical Center. She was a paramedic liaison nurse. She called me on the cell phone not a few weeks later saying, hey, Tony, I thought you might want to know this, because she was at the PMAC also. The PMAC is where all the county EMS shit happens. They had a 28-year-old Marine who came in for cardiac arrest. In the field, he presented as altered on the ground, and I think it was Station 11's IA. AMR got on scene, and there was basically an argument about whether we put him on a backboard or not, because they found him unresponsive on the ground, but didn't know I got there. So that AMR made that a case for their crews about belly aching with fire. The bellyache came afterwards, where fire, surprisingly enough, wanted to take a temperature of him because they didn't know what the hell's wrong with him. 28 years old. Okay, basically a super stud. And AMR said, no, let's just go, let's run. Now, I'm not picking at AMR, I'm saying the ambulance crew. And whenever people start saying, we just got to go, that means they're losing it. Unless they can articulate a reason. Listen, there's zilch we can do right now. I get it, but we got to get en route. Okay. But usually when people say, let's go, they're panicking. They got him to Inland Valley. He coded. They worked him for an hour. And after an hour, someone decided to take his temperature, and it was down to about 106. Now, you've seen the inside of an ER. It's cool. Okay, they had him stripped. And she said, we worked him for an hour before finally someone decided to take a temperature. I thought you'd want to know. What I could do with it, I don't know. I was just angry. Because I bet you with all the nurses and EMTs and physicians there, and a male, a 28-year-old guy, they're not going to just call it. Someone might have said, what about the H's and T's? Well, what the fuck does that mean if you don't know what causes them? If you don't check the things that lead to those? So he died, and it was just bath salts. Now, for the Marine, he's a jackass for doing that. But to me, it's almost like saying I didn't check a blood glucose and we treated the seizure all day long and never even looked once. How bad would that make you look? How incompetent and negligent is that? How easy of a test is it? That's, to me, that's the criminal negligence of the civilian EMS hospital system. We don't check the most basic shit, yet we make a big deal about electrolytes and acids and potassiums and crap like that. So that's that would have been something that if they walked in there and said, oh my God, the ambulance crew started cooling them off, right away and he coded, guess what? They would have got him back with good CPR. So this is, to me, what's frustrating. And if I sound like I kind of harp on it, is because I'm tired of seeing medics do the same shit over and over again. I pay lip service, get through school, forget it, I don't care. That's it. Simple stuff. So I try to make these situations recognizable so you see this is how it actually worked out. And this is something you can remember and put into effect. So any other thoughts, guys?
I had a question, Mr. Ritchie. You were saying like how you could kind of tell between like them having like a hypoglycemic seizure or like them being like epileptic. For people that are going through withdrawals and like have the delirium tremens, is there like a way for you to tell with that being a cause of a seizure? Or
I was going to say jail. That's going to be a little bit of a history thing. There'll be a little circumstances. And the second thing is their blood glucose will be, it's not going to be a factor.
Okay.
So I'm not saying pretending for a minute you can figure out what causes all seizures. There's many, many causes. I mean, everything that go wrong can cause a seizure. But these are conditions where if you find out, for example, circumstantially, this is why talking to people around them is such a big deal. When I talk to police officers, I'll say, what's the story? Oh, we picked this guy up. Do you guys know him? Because most cops know their local bums and junks and druggies and street people and stuff like that. That's a story thing. First, I got to treat the seizure. Okay. But you try to get some history because you're anticipating what else can go wrong too. And that too is good for the hospital. In other states, you've heard of the banana bag. I think Mr. Casares will cover this with you. It's basically the vitamin D deficiency. I think it's a thiamine and it's yellow. So they basically have, in some EMS systems, you give them basically a B injection for alcoholics because their seizure threshold is diminished through neurologic atrophy and damage. So giving them the banana bag or thiamine in IV is like a pretty common treatment to raise their seizure thresholds, but it's through a different mechanism. I would have to look it up. Nothing better I can give you on that. So they're not terribly common. Is just to pay attention when someone's DTs. The big reason is don't just look at them like, oh, they're fucking drunk, you know, they're tweaking, blow them off. It's more like pay attention because this person can go down on you and code. So don't kind of, you know, don't treat it like a Hispanic panic attack for drunks. It's a different thing. Did I answer your question?
yeah, it did. Thank you.
Okie doke. Chris?
I think I just need to turn in my videos to you via email. So I need to send you the links. And then I wanted to ask, can I send you my PCR for the aortic dissection? I was just confused where to turn that in.
You were here last week and that question was asked. So you didn't do the stuff until now?
No, I did it. I have it.
When did you do it?
I did it the day prior.
You did?
Yeah, I did. So I did the assignment the day prior in class, but I saw that like I messaged my squad and some said it was going to be in class and then there was like a link. So I wasn't sure where to turn it in.
Okay, send it to me. When did you do and your videos? So why haven't you sent me the videos yet? Because we talked about this in class too.
I uploaded them in the studio portion.
On your studio?
Yeah,
okay.
On your studio. Yeah.
My studio doesn't have them. The studio, send me what you got. And
okay.
So make sure to label that title the subject line so it's easy to see. So I have those.